Alrighty, so welcome. Good afternoon. Hopefully, yes, it's still afternoon for everyone, although I guess it'll be evening for some by the time we finish. So thanks for being in this for the long haul. Welcome to our workshop using simulation to promote DEI, diversity, equity, and inclusion in residency. This presentation represents a collaboration between the SAEM Academies of Simulation and Diversity and Inclusion in Emergency Medicine. None of our presenters today have any disclosures. I am Dr. Annika Baxter. I'm an assistant professor at Emory University. I'm also an executive board member for the SAM Academy of Diversity and Inclusion in Emergency Medicine, better known as ADIEM. I'm gonna let everyone kind of go down the list and briefly, all of our presenters, I should say, go down the list and briefly introduce themselves right now. I just have to unmute it. I think it'll work. So Cassie, Dr. Bradby.
Hi, everybody. My name is Cassandra Bradby. I am the Residency Program Director and the Vice Chair for Diversity and Inclusion for Brody School of Medicine and Vidant Medical Center here in Greenville, North Carolina.
Hey guys, my name is Michael Falk. I'm the current president, well, about to be the past president of the Simulation Academy for SAEM. And I'm also associate professor at GW and attending at Children's National Medical Center in Washington, D.C.
Hi, everybody. I'm Sarah Hawk. I am faculty at Rush Medical College in Chicago and an assistant professor there in emergency medicine, also simulation director at Rush for emergency medicine. And I'm part of the Sim Academy Executive Board.
Hi, everyone. I'm Kathy James. I am a pediatric emergency medicine attending at Boston Medical Center, assistant professor at Boston University Medical School, and I'm the rotation director for the pediatric emergency medicine rotation for the residents.
Hey, everyone. My name is Nate Jones. I'm a pediatric emergency medicine fellow at Children's National.
I'm Christina Lindgren. I am our assistant fellowship director at Children's National. I'm also an assistant professor through our academic affiliation at GW.
Hi everyone, my name is Jerome Martin. I'm the Rush Simulation Fellow in Chicago, Illinois.
Hi everybody, Lisa McQueen. I'm a pediatric emergency medicine physician at the University of Chicago, an associate professor of pediatrics there and director of our SIM program. It's great to see you all.
All righty, so again, everyone, welcome. And for those just joining, we're just going through the formalities, just getting started. Alrighty, so for this workshop, we hope to teach you how to use and design simulations in order to most effectively teach on topics of diversity and inclusion, or the very hot topic of being anti-racist. This is the outline for our workshop. Right now we're in the introduction section. This is gonna be 30 to 45 minutes. Plenty of time for questions, so please, if anything comes up, jot it down. You can use the chat as well. And then we'll have a 10-minute break, followed by our small group breakout sessions. These will be 45 minutes each. There's 3 of them. They'll have a 5-minute break in between. Those are sections, and then we'll have another 10-minute break, and then we'll have a bit longer of a debrief in typical simulation fashion and more questions from you all. Again, during the small group sessions, feel free to, sort of keep any questions, write them down, and you can bring them if you feel like they're more appropriate for the larger group. Yeah, just go ahead, jot them down. We'd like to hear from all of you, and we certainly, our goal is to answer all of your questions and make this as, minus the introduction, as interactive as possible. Come on, computer. Sorry, there you go. Sorry, okay. So, diversity, equity, inclusion, or DEI. Why does diversity matter, right? Well, diversity matters for our patients and for our interactions amongst ourselves and our learners. Let's consider the United States population for a moment. This is a simplified view, but you can see the shift in the proportion of the gray-white majority from 2012 to 2060. Data also show a shift in LGBTQ representation. A 2021 Gallup poll shows that 5.6% of the US population now identifies as LGBTQ. But note the large number in the more recent generations who identify as LGBTQ. You can see how 15.9% in Generation Z now identify. Now, let's also think about these numbers, right? So there's a 2019 survey that shows only 45% of the general population feels comfortable interacting with LGBTQ people in general. This tells us that there's work to do in getting people to just feel comfortable. Luckily, it seems many people are open to it, as in the same 2019 survey, 80% were also noted to support equal LGBTQ rights. Again, diversity matters for our patients. Consider the framework put forth by the Institute of Medicine, or the IOM. This is considered one of the most influential frameworks for interacting with patients and includes the following 6 aims for the healthcare system. Aims such as being safe, avoiding harm to patients from the care that is intended to help them. Effective, providing services based on scientific knowledge to all who could benefit and refraining from providing services to those not likely to benefit. Avoiding underuse and misuse, respectively. Patient-centered, providing care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. Timely, reducing waits and sometimes harmful delays for both those who receive and those who give care. Efficient, avoiding waste, including waste of equipment, supplies, ideas, and energy. And equitable, an important one for us, providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, and socioeconomic status. Let's put the IOM into context through the lens of the pandemic. Going back to the IOM aims, I say you consider our handling of the pandemic as at least examples in falling short of reaching aims in effectiveness and equity, right? Effectiveness in that because these populations have long been understudied, right? We haven't even studied them. So we're unable to provide services based on scientific knowledge. Equity in that we've failed to provide care that does not vary in quality because of personal characteristics such as race and socioeconomic status again. And while the COVID-19 pandemic has brought awareness to health disparities, with disparities finally starting to get the mainstream attention they need, it seems we still are continuing to fall short of the IOM aims. Consider the most recent flashlight on vaccine distribution, where they note, quote, according to newly posted CDC data, more than half of all American adults have now received at least 1 dose of a COVID vaccine, and a third fully vaccinated. Great, right? Yet a disproportionate number of those already vaccinated are white, with Black and Hispanic communities receiving a smaller share of the vaccine. So again, this is showing how we're continuing to ignore structural issues by continuing to ignore the structural issues in place that inhibit equity, we're just continuing to get these disparities. When thinking about how diversity matters for our patients and really ourselves, and the effects of the perpetuation of disparities, let's contemplate the minority stress model or theory. This theory acknowledges the relationship between minority values and dominant values, and the resultant conflict of the social environment experienced by minority group members. The Meyer, in the 2003 Meyer minority stress model, describes the stress processes and how stressors that arise from the environment require an individual to adapt, but also cause significant stress to the individual. Stress which ultimately affects their physical and mental health outcomes. So think of anxiety and depression and how they can lead to worse health outcomes, or consider how a person may have a constant worry surrounding their healthcare experiences. They may be worrying how their healthcare provider views them and thus how their healthcare provider is even going to treat them. And remember that this model is applicable to other social situations, like our interactions with colleagues and staff, which brings us to the fact that diversity matters for each other. Many institutions state goals along the lines of creating a culture and climate of equity and inclusion, where diversity is nurtured, valued, and celebrated. Why is that? Well, it's a chance to gain new perspectives. which can lead to new innovations. And really, this is what's going to lead us to better performance in the end. So it's important that we start instilling this understanding or keep reinforcing the value of DEI with our learners, because diversity matters to our residents and our students. From the Clinical Learning Environment Review, or CLER, they note a program is designed to provide institutions with periodic feedback that addresses the following 6 focus areas. These 6 areas are patient safety, healthcare quality, care transition, supervision, well-being, and professionalism. Again, you're starting to see some of that IOM overlap in these frameworks. In their 2016 issue, issue brief number 4, they found the CLER found a large deficiency in training for DEI. They recommended the next steps are to better define the knowledge and skills needed to recognize, address, and eliminate disparities in healthcare outcomes, and to identify how they could best be achieved during the GME experience. Additionally, the CLER data suggested that there is a need to define the expectations with regard to demonstrating healthcare improvement efforts aimed at eliminating disparities in healthcare outcomes. Which, you know, that's a mouthful. And it all comes back to, how are we going to do that? What can we use to put this into practice? How do we teach, or better yet, train skills in diversity, equity, and inclusion? Well, let's start with an understanding of an important concept in eliminating disparities: anti-racism. Anti-racism is opposing racism and promoting racial tolerance. It is action. From Ibram X. Kendi. To be anti-racist is to think nothing is behaviorally wrong or right, inferior or superior with racial groups. Whenever the anti-racist sees individuals behaving positively or negatively, the anti-racist sees exactly that: individuals behaving positively or negatively, not representatives of whole races. To be anti-racist is to de-racialize behavior, to remove the tattooed stereotype from every racialized body. Behavior is something humans do, not races. So let's go back to putting it into practice. Think about, what does it mean to be anti-racist, or really anti-bigotry, anti-discriminatory, anti-ist. These are all synonymous terms. They're used interchangeably. It's okay. You don't have to get too hung up on the wording here, right? Just understand that people use them, and that's fine. Understand that they're used interchangeably. So let's get in the mindset of putting this into practice. I like to think of being anti-ist as inclusive activism. To sort of explain it more, from the National League of Cities group, they state, not racists often refuse to a passive response to the generational trauma and pain inflicted on a race in the United States. It does not require action. Again, being not racist does not imply nor require action. But let's understand that racism has a foundation upon which our society and institutions are based. Thus, anti-racism must also be a system in which we act to create policies, practices, and procedures to promote racial equity. Simply being not racist does not require active resistance to, nor the dismantling of the system of racism. Here are 6 steps from a site called Giving Compass that kind of can help you with being anti-racist. And these are 6 steps because, again, it starts with us, right? It starts with you acknowledging your own beliefs. And so here's 6 steps that might help you. First one, understanding the definition of racism or bigotry, check. That it's no longer enough to say, I'm not racist. Identifying racial inequities or disparities in you, around you, right? Confronting any bigoted ideas you've held or continue to hold. Understanding how your anti-racism needs to be intersectional, that's important. And then championing anti-racist ideas and policies. So in summary, this is doable. We can all do this. We can all promote it, support it. We can teach it. If we just need to acknowledge first that diversity matters, right? Then we can understand that promoting DEI is a means to combat health disparities. And we acknowledge that we should be incorporating anti-racism into our daily lives, as well as teaching it. And what is one way to do that but with simulation? with this, I'm going to turn it over to Dr. Michael Falk, who will introduce you to using simulation and being anti-racist or anti-bigoted.
Can you just, Annika, can you just do the slides for me? Do you mind?
Yeah, I absolutely can.
All right. So, hey guys. So I come at this from a simulation background, and you know, the first time we ever did this, we hosted a workshop about 2 years ago, and that's where this sort of idea came out of, because it was sort of, it was so well received and people were so positive after the fact. We wanted to take a chance to explore it more and see if there were better things that we could do. Next slide, Annika, please. Sorry, I'm a pacer and a hand guy when I talk, so Zoom is not my natural element, so apologies in advance. You know, for those of you who don't do simulation, I'm just pretty sure everyone's experienced, but if it's not your main go-to mechanism for teaching, I think it's pretty clear that simulation is now considered an essential part of modern emergency medicine. But we have to think about, what does simulation teach? And this is one of the things that people always miss. We don't teach medicine. I don't teach medicine. I don't teach you myocardial dysfunction. I don't teach you that. I teach you teamwork, communication, leadership, and all of the group dynamics and things that go on within an emergency situation. So if I can do that, if I can, or the simulation community can teach you how to deal with an emergency or a stressful situation, why can't we teach how to deal with other stressful situations like encountering racism or other issues of inclusivity within the workplace? Next slide. So just as a quick high fidelity, simulation involves lots of different tools. I think most people are probably familiar with all the high fidelity mannequins, but you know, there's lots of other ways you can do simulation. There's role plays, standardized patients, which we forget about. OSCEs are a type of simulation. And all of these are great tools for teaching what I mentioned, but they're also good tools for revealing errors in communication. And that's one of the interesting ways. So that the idea would be that you can reveal like mistakes people are making, maybe even subconscious ones that they don't realize, that are actually biased judgments of people in the workplace. Next slide, please. If you look at the ACGME, interpersonal and communication skills and professionalism are established domains for emergency medicine training. They are also within the EM milestones, which we all have to comply with now. So there's professional values, accountability, patient-centered communication, and team management are all essential milestones that EM residents, as well as pediatric residents now and other residents due to the milestone project, have to meet. Next slide. So some research out there that looks at what can we use simulation to do in a more non-traditional means that people don't normally think of it for. So people have been using, this was a survey done of simulationists across a variety of emergency medicine programs, and people were using simulation to teach interpersonal skills, to teach how do you behave professionally within a variety of settings and contexts. And also, interestingly enough, it was used in remediation. So it was used for residents who were failing at all of these aspects, and they were using simulation to train people to be better communicators, working on their interpersonal professional skills. The milestones themselves are starting to be adapted now to simulation-based didactic and assessment projects. And one of my colleagues from the Sim Academy, Naran Nadir, wrote a paper on this called the ACGME Milestone Project. But that only gets us so far. So next, people have used simulation in a variety of areas to deal with things that are, and I would argue in many contexts, related to dealing with issues that make people uncomfortable. So for example, anesthesia residents were given simulations on breaking bad news. And they use that, and they use simulated role playing on how to break bad news. And not only did their performance improve, but their ability to deliver bad news and their stress around it declined with more training. Same thing was done with NICU and pediatric residents. And all of them felt that they were not they just felt, but when they were evaluated, the evaluation showed that their skills were much improved on breaking bad news. There's a great example of this is there's a longitudinal, there's a tongue twister, longitudinal skills course for medical students with simulated difficult patient and situation encounters, where they actually had patients confront them in the waiting room, being belligerent, a whole bunch of things, and also just breaking bad news. So There are lots of examples of using simulation around communication that is difficult for the provider and the patient. And I would argue that dealing with issues of discrimination, racism, and other sorts of problems in the workplace are pretty much related to these. And I will prove this, I hope, later on. Next slide. So another great example of this is a study by Petit et al. They use simulation just as to this was to uncover bias within the residents themselves. And they had two patients, standardized patients, both with ACS presenting in the emergency room setting. One was homeless, poorly dressed, and an alcoholic. And the second was a white collar executive, clearly more affluent, very well dressed, the exact opposite of what we see in the first patient. Students assigned to the white collar executive were showed better communication scores and dealt with the patient better. And the students who were assigned to the homeless, poorly dressed one actually did not perform as well. Interestingly enough, when they're debriefed around this, most of the students claimed to be very unaware that they were actually doing this, and they thought that they were being objective in their approach to patients in the workplace. Next slide. There's some papers out there on actually using simulation/medical education for teaching diversity and inclusivity. There's a great review of the literature. I did not make this title. The grammatical errors in it are not mine. Toward cultural competency in healthcare. And it's a systematic review of the literature looking at what has been done so far from a medical education standpoint. In their paper, they found 82, this is where I have to go to my notes, apologies. There we go. If you want to go to the next slide for me, Annika. There was 89 articles in total that they found on diversity and inclusivity. And they covered an entire gamut. They went from literally a 1-hour lecture, which I'm sure many of us have gotten historically on exactly this topic, to actual dedicated curriculum that were longitudinal and people had to take over the course of a number of months. Interestingly enough, 78% of them looked at undergraduate and graduate training. They didn't even address faculty. And what was surprising to me is 2.5 of them, only 2.5 of all of these courses actually focused on skill acquisition and training and skills so that you could confront these situations in a more comfortable manner for yourself. Just an example, so they had like the courses, there was lectures, there were online courses, they had discussion groups. Some of them were more case-based and role-playing. There's standardized patients have been used, OSCEs. But like, as I mentioned above, in the vast majority of these situations, nobody actually teaches anybody how do you deal with it when it happens? How do you confront them? How do you feel comfortable confronting a patient, a colleague, an attending, a nurse, anybody in the workplace if you feel that they're being racist and or bigoted towards a patient or another provider? Next slide. This is, I got to thank Lisa McQueen for giving me this paper. This is my new favorite paper. So this is a paper of Rishkin et al. It's in Pediatrics in 2017. And I don't know how I missed it, because this is, I honestly think anyone who's in simulation, please read this. It's brilliant. I will go on for hours on this paper now. But this is really interesting. And I'll mention their previous research after I lay out just what they did. So they looked at what is rudeness in an emergency situation due to the dynamics and the characteristics of team performance. So they took 39 NICU teams. Just quick background. For anyone who's familiar with simulation, I think some of you know, Israel has this phenomenal simulation system. For example, to graduate medical school, everyone goes to this national sim center and they do OSCEs and simulated patient encounters. That's how you get your medical license. So they actually have the capacity to do this. So they took 39 NICU teams. There are 2 MDs and 2 nurses in each team, and they were all tasked with 5 patient scenarios over the course of a day. And each team, 2 teams either had a rude patient, or a neutral parent. And the rude parent would literally make comments like, "Why did we come here? This is basically third world medicine. We should have gone to another hospital." Furthermore, 2 more of those teams were actually, when they were assigned the rude parent, they were actually trained to deal with rudeness through 2 different mechanisms. So we can go to the next slide. I want to give you a little background. Can we go to the next slide, Annika? Sorry. I think that's where I get into the background of it. Yeah. So go back one slide. Yeah, the reason they wanted to look at team behavior is in their previous research, which is also interesting, mildly rude or questioning behaviors. So this was a colleague or an attending physician to somebody in a more junior position to them would make statements undermining their authority or their ability to practice medicine. This actually led to decreased performance in the person's cognitive tasks. They showed decreased creativity and flexibility in their thinking when evaluating and assessing patients. They also, interestingly enough, they became less helpful to others. And what's really fascinating to me is these changes are seen both in the person who's the target of the rude and inappropriate behavior, but also people who witness it. As there was some impact on their performance as well. So if we go to the next slide. So when they actually ran these scenarios, rudeness actually caused almost 40% variance between teams and the therapeutic outcomes. This isn't just like how you talk to each other. There was, and I'll give you the actual scenarios so you can get like these. They gave them like really difficult cases. I was really impressed. But so the variance was actually on their ability to diagnose, assess, and deal with the problems at hand. Their interventions, there was more diagnostic and intervention areas. There was more issues in team functioning and their ability to communicate with each other, their ability to help out each other, which also leads into their ability to information and share workload together within an emergency context, which is critical when resuscitating a critically ill patient. Where is it? Just so I can give you, yeah, so just to give you an idea of what they were like, how, sorry, my dog. To give you an idea of how stressful these situations they gave them. So they had 5 separate newborn resuscitations. One was a neonate with severe jaundice who needs a double exchange transfusion. A newborn in hypovolemic shock with a subgaleal bleed and a coagulopathy. These guys are really mean. I'm actually quite proud of them. A newborn with severe respiratory distress after meconium aspiration, who then requires nitric and gets a pneumothorax. Severe neonatal hypoxic injury that required cooling. And last but not least, the easiest case arguably in this was the delivery of a 23-weeker and its subsequent resuscitation. So they gave them like incredibly complicated tasks to perform. And just that statement, why did we come here? This is like third world medicine, actually caused them to have more errors and led to bad outcomes in the patient. So I think that's really a pretty amazing study, and I'm not doing it justice, so it's worth having a look at. Next slide, please. The two treatment groups were actually given interventions. One's called CBM, and it's a cognitive behavioral technique where they actually, quick version, they gave people pictures of faces to look at, ranging from angry to happy. And they asked the people to identify angry versus happy, and then they transitioned the faces through. The second intervention they did was something called a therapeutic intervention. It's a narrative experience. So after their first experience with the rude mother, they would sit down and they would write a narrative of it. And this has actually been shown to help patients who've been sexually assaulted deal with PTSD after the fact by writing a narrative of it and sort of redetermining the context of that PTSD experience. Interestingly, the CBM training mitigated the impact of their rudeness on the team function. And actually, the teams who had that training performed just as well as the teams who had a neutral parent. And that, to me, this is a really interesting point. But the narrative intervention didn't work. So I think this is really interesting because we go on the next slide. I think you can make a very reasonable argument that quote unquote rudeness is dealing with people who are being discriminatory and rude in the clinical context. And that what it suggests is that you can actually train people, or we can train people if we think about things in the right fashion and use the right educational intervention to mitigate the impact that it has. I also think it's fascinating that people being rude doesn't just impact how you personally experience your day, but it impacts how you provide care. It impacts how you think about patients. It impacts how you work with other people, which I think is really, it's such an obvious thing when you read through the paper and get to the end of it. It's like, why didn't we do this beforehand? Why didn't somebody look at this earlier? It's so amazing to me. To tie this into the larger picture, there's a study out there looking at internal medicine residents and the frequency within which they deal with derogatory comments in the workplace. And if you look at all 300 plus internal medicine residents in this study, 14 experienced one or more belittling comment a week. 17% of them had to deal with the assumption of non-MD status. Now, obviously, that is going to be different for various people. So 45% of Black and Latino residents experience racist comments or refusal of care from a patient in a weekly setting. 100% of Asian residents had experienced the questions about what country you're from, what's your ethnic origin, things like that. And female residents, 96% of all female internal medicine residents have encountered comments about their job status. And then even more depressingly, 87% of them experience sexual harassment during the course of their residency. So, I mean, this is going on at arguably a daily, if not weekly basis for many of our residents, colleagues, and other providers. And we just have to assume that it's got to be impacting care and how they deal with people. It's interesting to me that fully 1/3 of the residents didn't report this because they felt it was more important to prioritize clinical care. And then 1/4 of them didn't report this because it felt it was futile and there would be no positive outcome for them. But 90% of them did say it was a significant and important part of their training. Next slide. So depressingly enough, and I think most of us probably realize this now, harassment is common in healthcare. It occurs for our patients, it occurs for us, it occurs between us, amongst us, all around us on a daily basis, whether or not we're not actively participating in it. And I think, we can make a leap from that study by Rishkin and argue that this is rudeness, and this probably has an individual, if not a team impact on how care is provided in the real world. Also, encouragingly, it actually suggests that we can probably train people in a certain way to deal with it. And that's hopefully the point of this session, is that to start sort of scratching the surface on, is there an educational model that we can come up with, or a variety of models that we can actually use to intervene on these sorts of behaviors. Thank you. Whew, I can take a breath.
So I think we've got the why this is needed, and I think we're starting to see a potential how we can do it. So we're actually really good as anticipated. We are quite good on time. Does anyone have questions? You can put them in chat. So I'm gonna pull off my share screen.
And I have questions for you folks. If you guys, I'm gonna do the pick on people and ask questions. But please feel free to throw any questions out there. If you want to speak directly, please feel free. No one? Yeah, we will be making the slides, and we're putting together a reference list that we'll happily share with the participants after we're done. So let me ask, one of the things we wanted to know was, what's your reasons for taking part in the session? Or are we using simulation actively? I have. It can be problematic. And I think you have to be really careful about how you do it and where you do it, especially with setting up the ground rules about how you're going to proceed. Sarah, you've done some too, right?
Yes, Jerome and I have done several sessions recently. And so during our small group, you'll have a chance to see and maybe even be a part of an example.
But can I ask you folks, what was your primary motivation for taking the course? And just being curious.
Hey, Dr. Falk.
Hey. Cortland, right?
Yep. Well, that wasn't me, but this is me. I don't know who was speaking, but I can answer the question. So my name's Cortland, and I'm Vice Director for DEI at Atrium Health Carolinas in Charlotte. I have a couple different research projects. One was actually looking at, similar to what you were saying, with the discrimination and micro and macroaggressions that individuals in internal medicine faced. I'm doing a similar, I just completed a similar project on emergency medicine residents and trainees and faculty. And then my other project is actually looking at the gender and racial breakdown of high fidelity simulation mannequins across the country, and to see if they accurately represent the US patient population, and then to see what % of training programs are actually using high fidelity simulation to teach an aspect of cultural humility. So this is right up my alley, and I'm excited.
Anybody else want to share?
Hi, I'm Miriam Malaka, also seen as Mimi on the screen. I'm actually a resident at Henry Ford Hospital. I'm the incoming chief resident, actually. And then I joined this because I was very interested to see how they were incorporating simulations into their curriculum. At Henry Ford, I know we have an institutional curriculum where we do a microaggressions workshop, and I was just trying to find ways to make it more effective and hopefully leave here with some of those tips to bring back.
Full disclosure and backstory, part of what this group is working on is actually trying to create a semi-validated curriculum that we will share at the SAEM website when it's done. So the goal is to actually to try to create tools that we can use to intervene.
I'm excited to learn. I won't be able to stay the whole time because I have a shift, but hopefully I can.
I can introduce myself too. Hey, I'm Adam. I'm a PGY4 at Boston Medical Center. Hi, Kathy. I'm going to be the medical education fellow at the University of Chicago next year. So over the course of residency here at BMC, I've sort of been involved in a lot of DEI projects, very much involved in medical education. And so I've sort of, we did this project where we sort of we did this lesson plan with medical students sort of about recognizing bias. And a lot of the projects that I've done have involved SIM. And I sort of, over the past year, been thinking about ways to sort of actively engage in this self-reflective process of sort of identifying bias in different clinical scenarios, and taking it more from a place of not just saying like, oh, okay, I recognize in that moment that I was probably having a little bit of bias in that patient interaction, but sort of taking it to the next step in terms of sort of clinical outcomes. And so I know one thing that we've been talking about and thinking about is race and the use of restraints in the department. And sort of some of the direction that I think about taking my sort of master's program has been sort of in this sort of intersection. So just trying to learn a little bit more about what's going on, sort of like looking at some of the research out there just to sort of inform my like sort of projects and master's choices coming up.
Hi there, I'm Sonia. I'm a PGY4 EM resident. I'm going to be a simulation fellow starting in July, and I have an interest in exploring gender bias within or among residents and in healthcare. So I wanted to learn how to incorporate additional tools to explore this and address it. So that's why I was interested in this talk.
Wow, so it looks like we got some really great representation here. Thank you guys for signing up. Hopefully we will meet your needs, hopefully. Again, the part of the process here is going to be ongoing. So we've already done a study with focus groups from across academic emergency medicine, looking at what are the barriers and other issues around teaching diversity and inclusivity. And the next step is probably going to be to create a curriculum based on a modified Delphi survey. So if you want to participate, just throw it up in the chat and we will happily be reaching out to folks afterwards. Anything else, Annika? Here's an interesting question. Let me ask folks in general, and it's because it was listed one of the things we wanted to ask. What are the sort of barriers that people have experienced when trying to do this sort of teaching in your institution?
I think for at Henry Ford Hospital, I've gotten a lot. It's hard to get people to actively participate, especially when we do our small group sections. I think people aren't comfortable sharing their experiences. And I think the other thing I've noticed too, is especially when there's like faculty along with residents are more hesitant to share their experiences.
Which is interesting because the Rishkin study on the individual behavior, it was actually a senior lecturer who was talking down to the junior faculty that led them to perform poorly in the resuscitation. And not an uncommon experience. That's a great point in the chat. We'll be exploring it more, but it's true. I mean, a lot of simulation mannequins do come in a variety of colors, skin tones, that is. But truthfully, at $50,000 a pop, as a guy who used to run a sim center, you're kind of and I inherited my equipment, so I was stuck with whatever skin tone mannequin was purchased prior to my arrival in the department. But no, it's a real problem. It's that the mannequins themselves, I mean, well, A, they don't look a lot like humans to begin with, but B, when they don't represent a significant proportion of the population either.
I mean, I also think doing a sim case with a mannequin versus like a real life person in front of you is much different, right? Like, I think if you're trying to sort of identify potentially prejudiced behaviors and conversations, like I think it is much more difficult on a mannequin to sort of identify those problem areas than if you have like a simulated patient in front of you or like a real sort of participant. And I feel like in trying to pursue some of these projects, that's one issue that we run into.
That's why I wanted to bring up at the start, people forget with all the bells and whistles and the fancy mannequins that there's a lot of ways you can actually run scenarios with people that are good. One of the things you have to be as a simulationist, one of the things you have to be careful about is causing damage to the people who you're running the simulation with. So if you're going to deal with a particularly charged situation, make sure that the person pretending to, the people involved, like with standardized patients and stuff, you can get a lot of damage done if you don't run the scenario well. Sarah, you agree?
I was just in the middle of trying to type that. So in response to the needing, good actors and good scripts, you absolutely do need to think through the situation quite a bit, but also trying to avoid asking folks who share a background with the marginalized groups you're asking to be a part of your simulation. You can potentially re-inflict some traumas on these people. And so one of the things that I've been looking into is how to support faculty with limited experience, specifically related to marginalized groups, how to help them portray these marginalized groups, perhaps for these communication sims. So you'll see that a little bit later.
Awesome. Okay. Well, we are at 12:50. So with that, I think we can take our first 10-minute break and we'll move you all into your small groups and then we'll start our small group fun session.
5-minute break, isn't it?
Well, so the first one's supposed to be a 10-minute.
Okay, my bad.
10 then 5s.
All right. So Evan, do you want to break us into the groups and then we can all take a break after we're in our groups?
Yeah. How would you like these named or organized?
Oh boy.
Just
Yeah, I can leave them as room 1, 2, 3,
Yeah.
and I could
that works.
put your pairs in each one so that it's already done.
Perfect. Thank you.
Yep.
Oh, and by the way, for anyone who cares, I just talked to my mom. She sounds fabulous.
Yay.
Yeah, awesome.
That's awesome.
She hasn't gotten up yet, but she will anytime now.
Tell her there's people all across the country who
Right.
are cheering for her.
She has a nationwide fan club.
Oh, I know. Yeah, she and her ladies in her 80s.
You're gonna have to shoot us an email of her when she starts playing tennis, or like a picture of her when she
Yeah.
starts playing tennis.
Yeah, she's really so excited about playing again because she was so bummed to have trouble playing. So I'm just really happy. You guys, you don't know what a relief this is for me that she's done with this. Whew. Thanks. Okay, just wondering if the 2 people with their video off are here. You back from break? You ready to start? Ready to do this thing? For everyone in the group, my mood has exponentially gotten better. My mother had a hip replacement this morning, and I just spoke to her finally, and I'm a much happier person now. So you all get to share this experience with me. All right, well, you know what? Let's do this thing. I will share my screen. I'm assuming the other 2 will be back in just a moment. So welcome to our session. This session, we're going to be talking about using role play to teach people how to respond to racism and bias in the workplace. I'm Kathy James, like we said before, and I am a pediatric emergency medicine doc at Boston Medical Center, obviously in Boston. And I am the rotation director for the PDR rotation.
Hi, everybody. I'm Cassandra Bradby. I am the residency program director and vice chair for diversity and inclusion at Brody School of Medicine at East Carolina University. That is a mouthful. And Vidant Medical Center in Greenville, North Carolina.
Hey everyone, my name is Nate Jones. I am a pediatric emergency medicine fellow here at Children's National Hospital in Washington, D.C.
All right. So as we mentioned before, none of us have anything to disclose. So why are we talking about this? We're talking about this because, as all of you probably know, racism and bias in healthcare settings, it's a really common problem. And it can be directed at patients by the healthcare team, but also it can be directed at the healthcare team members by patients or other team members. When it's directed at patients, it can affect their care. When it's directed at providers, it not only affects patient care, but it also causes stress that can lead to burnout and can even lead to staff leaving. So it's really important to learn ways to deal with these situations when they arise, whether you're the target of the bias or whether you're a bystander. So the objectives of this session are first to define microaggressions, so we're all on the same page, then to demonstrate how to use role play to teach people how to respond to racism and bias, and then finally to review some intervention strategies to respond to racism and bias. So start with the definition. The term microaggressions was first coined by Dr. Chester Pierce in 1970. And then more recent work, a lot of that has been done by Daryl Sue, who is a psychologist. What microaggressions are, as you can see, brief and commonplace daily verbal, behavioral, and environmental indignities, whether intentional or not, that communicate hostile, derogatory, or negative racial slights and insults to the target person or group. Now, by micro, we don't mean these things necessarily are small, but what they mean by that is that they're everyday occurrences that are on an interpersonal level, not necessarily a systemic level. They're not always verbal. Sometimes they're behavioral, like ignoring someone or not making eye contact with them. And they're not just about race. They can also have to do with religion, nationality, sexual orientation, gender expression, disability, or any other identity. And the big problem with microaggressions are they can lead to stress and burnout. And when you think about your trainees, these can also interfere with learning by increasing their cognitive load. So Dr. Sue had divided microaggressions into 3 different groups. One are the micro insults. Those are can be unconscious and are remarks or comments that convey rudeness or demean a person's identity. Another kind of microaggression or micro invalidations, which also can be unconscious. These are comments or behaviors that exclude, negate, or nullify the thoughts, feelings, or reality of a person in a marginalized group. And then there are micro assaults, which is really just good old-fashioned racism. And so these are often conscious. These are often verbal or nonverbal attacks that are intentionally meant to hurt the person, whether it's name calling or some other kinds of behavior. You can use role play to practice responding to all of these. The thing I didn't mention on this slide are also macro aggressions, and that's institutional and structural racism, which are not something we're going to be talking about here. So microaggressions can take all kinds of forms. Where are you from? No, where are you really from? That person's so articulate. You're the doctor? And then, of course, the racial slurs that we might hear every day. So all of these things might seem like they're small, but they're cumulative and they add up and can lead to stress and othering the person that they're directed at. So what's role play? Role play is an experiential learning technique that lets learners act out roles in case scenarios. When you do a good role play, you have targeted practice of communication skills and feedback to help improve your performance in the future. And we often think of role play to use it to practice communicating with patients, but we can also use role play to practice communicating with colleagues and communicating with other members of the healthcare team. So, how many of you have used role play in education? Anybody? Yes, no, not so much. All right, because I was going to ask if you did use role play, what did you use it for?
We've used it in Rochester. We have a really large deaf population in Rochester, and so I set up standardized patients with some of my deaf colleagues and had them be the standardized patient, and then had my residents essentially do a history with them and provide them some information, and then the deaf person provided the feedback on how the interaction went.
Wow, that's really terrific way to use it. And there's a group I didn't even mention, deaf patients. That's a group that could certainly be the target of a lot of microaggressions and discrimination when they come into a healthcare setting and just in life in general. Did that work well? Did people enjoy that and feel like they learned a lot from it?
Yeah, I think it went over really well, and we got some really positive feedback from the residents, and the community members felt really empowered in doing it.
Oh, that's terrific. I like, that's one I'll have to make a note of because that's a really great one to do. I really like that. Oh, that's awesome. All right. Well, role play is something you could often also use to confront racism and bias in the workplace. Another way to do this could be using standardized patients, but standardized patients can be tough to find. They're not always available. They have to be trained. They can be kind of expensive. And I guess the nice thing about them would be that they could take some of the emotions out of the situation, but you can't always use them. So when you use role play, it can let trainees practice rehearsing hard situations in a space that's more of a safe space. When we are in an actual patient situation, it can be really hard to build rapport with a patient who's exhibiting bias, but EMTALA says we have to do a medical screening exam and stabilize them no matter what they say to us. And ignoring racism from patients that's directed toward your colleagues is terrible for morale and really hurts your relationship with them. So we could use role play to practice some specific methods of responding to bias. So let's go through the steps of role play, but what we really want to emphasize are some points that are important when you're using role play to learn how to respond to bias at work, whether it's racial bias or some other kind of bias. So let's go through the steps. First step of any simulation role play, however you're doing it, is preparation. First thing you'll need to do is develop your objectives and decide who your participants are going to be, because it shouldn't just be the doctors, right? You should have everyone who is in your work area be a part of this to make it multidisciplinary. Next step would be to choose cases and potentially write some scripts for them. And then after that, you may want to distribute some pre-reading to the participants so that they have some familiarity with the situation before you start the role play. So where are some sources you can get your cases? One possible source would be to poll your department, poll your students, and get cases from your own and your participants' experiences. One thing that's good about this is that the scenario takes place in your setting and can address some issues that are really specific to your learners. A thing that can be tough about that, though, is then if someone submitted something and they participate in the role play, they have to keep hearing that situation over and over again. Another place you can get cases for role plays from published sources. MedEd Portal had, in 2020 and 21, I found 4 workshops in MedEd Portal that address microaggressions at work. Another place you can get them is to write scenarios yourself. Now, this might be a little difficult when you're dealing with a subject like this, because you might be even introducing more bias into the scenarios that you're writing. But whichever place you get your cases from, you probably want to consider writing some scripts for the person who is the source, the person who's exhibiting the bias, because these topics are pretty sensitive and you don't want that person to have to sit there and make those things up on the fly. Also, you don't want the other people in the group to think those words and ideas are really coming from their coworker. So once you've done all this and you get to the actual role play, the first thing you want to try to do is create a safe learning space. So do this in a private area, turn off all your electronics, and then remind your group that everyone's opinion is respected. Everyone is learning, so they might make mistakes. And also, whatever happens in role play stays in role play. Some people like to start off with an icebreaker of some sort at this point. You can decide whether you want to do that or not, depending on how well the people in the group know each other. Then after that, set the stage. Make it clear what the objectives are for the session and give some background for the scenario that you're going to be using. If you're doing it in person, that might be something that you hand out on a piece of paper. If you're doing it virtually, that's something that you can put up on the screen, or you can put in the chat or something like that. Another thing to know at this point too is how long you're going to be giving for the role play, so that people know how long this is going to last. And again, acknowledge again that this can be stressful. Dealing with bias is stressful, and let the trainees know they can call a timeout if they need to. So as far as assigning roles, there are a few different people you'll need if you're doing a role play about responding to bias. You'll need the source of the bias, the recipient of the bias, depending how many people you have, potentially some bystanders. And if you have even more people, you might want to select one person to be an observer who doesn't actually take part of the scenario, but they're watching everything that goes on, potentially taking notes about it. So people are probably going to be uncomfortable with this sort of role play, but you don't want to force anyone to play a role that makes them really too uncomfortable so that they won't even be able to perform. Something that might be helpful if you were talking about a subject like this is, instead of having them play themselves, give them a different name to use, just make them a character. So the person who's saying those things isn't really them. Also, you'd like to be aware of who gets what role. If you're whether you're having people volunteer for the roles or you are assigning the roles, don't always give a member of a minority group, don't always give them the role of whoever is the target of the microaggressions. Another thing you can do with this is, if you don't feel like your participants are going to be as comfortable with being able to either be the source or the target of a microaggression, you can have the target be someone who's actually not even there, and have the source of the microaggression talking about some fictional person who's not even there, and say you're the bystander in the situation. Another thing that you might need to do is you might need to play the source of the microaggression if no one in the group is really comfortable with doing it. And then once you've assigned the roles, give people a few minutes to read the scenario and think about what their role is. During the actual role play, a few things you might want to do. You, as the facilitator, and your observer should really pay attention to see if anyone is getting really upset and you need to stop the role play at any point. Remind your participants to not sort of overact, not use foul language, racial slurs. Even though we know patients are going to say that sort of thing to us, we don't want to talk to our colleagues that way when we're practicing these scenarios. And also keep an eye on the time limit. So what if things do get a little out of control? If people are getting too emotional and upset, if people are just not moving moving forward and making progress, or if you feel like you're getting interruptions from all over the place, you might need to call a timeout. And this might be a good time for you as the facilitator to role model how to interrupt problematic comments that were made during the role play. So finally, once you're done, the first thing you want to do in a situation like this, call people by their actual name so they can sort of shake off the role and go back to being themselves. And then the next thing you want to do is ask all the participants and your observers, how did this feel? What went well? What could have been better? And take the time to do the debriefing and make sure that everyone feels like they were heard and feels like they're safe at this point. And then finally, you want to summarize the role play that you've done. Make sure to really emphasize the take-home points. And at this point, you might want to give your participants some resources. You might want to give them a pocket card or put signs up in the bathroom or somewhere to remind people of the different steps that you would go through to respond to these situations. Also, make sure that your learners know what the institutional contacts are if they need to file a report, or if they need to talk to someone sort of higher up if they've experienced issues with microaggressions and bias in the actual workplace. And then finally, you want to plan your next steps, because this role play should just sort of be one of a series of steps that you're doing to help your trainees to learn how to deal with these situations. So just to summarize, what makes a role play effective? One is good preparation. Really think about your cases, think about who's going to do what, make clear objectives for it, set a time limit so it doesn't go on forever, and then have a really good debriefing. One of the other groups is going to talk more about debriefing today. Another thing to remind people, in role play, we're all safe, but in a real life situation, if the patient is actually violent, that's a situation that you might want to take yourself out of and not try to do this stuff. So now that we've talked for a few minutes, let's actually practice, because that part's more interesting. So in a role play, we have already done the first few steps. We've prepared for this. We've chosen some cases. You'll actually get in the reference list a link to the MedEd portal module that has these cases in it. We have not sent them out beforehand, but we promise you'll get them afterwards. So we want to make sure everyone knows this is a safe learning environment here. What happens here in role play stays in role play, except that we're being recorded right now. And also, let me set the stage. So what we're doing, our objective now is to practice responding to racism and bias in the work setting. So Nate, take it away.
Okay, so this is our first of two scenarios that we want to run through. We're gonna need your participation for this. So if you want to take the next minute or two just to read through the scenario, and then we'll think about assigning roles and we'll play this out. Exactly, yeah. Okay, so hopefully you got a chance to just skim through this. Does anyone want to pick? So there's four roles that we're gonna have. One will be the professor, who's part of the scenario, and then the recipients will be the students, and then we'll have a bystander who will also be a faculty member as well, and then an observer to help observe the whole situation. So does anyone just reading the scenario want to be a particular role right away, or should we just go ahead and assign? I want to see if anyone wants to sort of jump up, if anything jumps at you.
Remember, what happens in role play stays in role play.
Exactly. And the scenario, yeah, the scenario is actually extremely short, just like most microaggressions you experience in real life. They're very short and very passing. So we want to sort of have this sort of a real life experience with that. So they're going to be no more than about a minute or so. So they're relatively short. So
I'm happy to be the be who I am, a white male professor who, probably has inadvertently and mistakenly, said something like this in the past, although I hope not in any recent past.
Okay. All right. Can we have someone for the students?
I don't mind being anyone that's helpful.
I'll be anyone.
Okay.
Can I ask a quick question, or do you want me to wait until?
Go for it.
In doing this exact thing, trying to get people to be a specific role, a problem that I would foresee in my residency is that we don't have very good faculty representation in terms of different races. And so I would feel awkward playing somebody who I am not. I would feel sort of like an imposter, and maybe that would be insulting to minority residents. And also I would feel as if I am imposing sort of that minority tax on on one of my minority residents, or the very few minority faculty that we have, and asking them to do this. So how do I go about doing that?
One way you can do it is if you don't really have any people who kind of fit whichever group you're talking about, that's when you can have it being a conversation, say, between you and someone else, and have the person who's sort of the target of the microaggression not be there. So you're talking about a scenario that is happening to someone else, and then you can be sort of a bystander in this. So you still have a way of responding to it, but you can not try to make yourself someone you're not. So I think when you're doing stuff like this, we wrote these not knowing exactly who our participants would be, but if you're doing this in real life, you're going to have more of a sense of who's in the group. So that's one way you can decide how you're going to do this, is potentially have it directed against someone who's not actually there.
Okay, thanks.
I think you can also crowdsource. So like at our institution, we sometimes bring in folks from other departments who've done similar workshops, so that it's not necessarily the people that they work with every day doing these things. The other thing is, if you have the budget for it, simulated patients are also helpful with this, but you would need to meet with them for probably like an hour beforehand to kind of prep them. This is what's going to happen. These are the things that we're discussing. Yes, we know these are uncomfortable conversations. Please let us know if you are uncomfortable during this, because I think it might be hard for them as well. But so you'd have to do some pre-work on that. But that would be another way to kind of get you a little bit more support and a little bit more people involved, like outside of your department. And I also think that sometimes helps when you're having the uncomfortable conversations, is like people who are less, we're going to call them less risky, because like you don't directly report to those people, right? So they don't have any sort of dominion over your career. So it's a little bit easier to have some of those conversations.
Right. Absolutely, because that's a thing that's hard in real life, but would be hard in role play also. What Cassandra just mentioned, if you have a student or a resident and a faculty member, even just when you're doing the role play, that could make the student feel a little uncomfortable about speaking up. So you want to maybe get some other people in there too.
Okay, so maybe so I guess Ryan and who was the other individual who didn't care? I don't know. Sonia? Okay, you two want to be the students, and then just one person will just be the bystander / observer. Sound good? Cassandra's going to send you the lines through your chat, so just look at your chat. Already sent? Perfect.
Yeah, and this is sort of the basic part, and then the part you'd sort of do in the role play is sort of figuring out where you want to go next with this stuff.
Mm-hmm. So we'll give you the lines to start, and then you can sort of ad-lib the rest of the conversation. So we can start. So to all set the scene, so you have two Black male medical students, Rashid and Davion, who are in the elevator, and there are two other white male professors, and the conversation starts.
Do I acknowledge the students first?
Sure.
I'm sorry, where are the lines?
It should be in your chat. Do you see it?
Dr. Bradby.
I see him.
Oops, sorry. I didn't mean to move. There are very few lines.
Yes, those are very short. Okay. So we can start the scene.
All right. Oh, hey guys. How's it going? They didn't kick you out yet?
Nope, we're still here, sir.
This is the ad lib part.
Oh, I just meant because the classes are so rigorous.
Oh, I felt like we did okay on our test. No one told us that there was a problem.
Oh, good. I'm glad to hear that. I don't know what else to say.
That was tough, right?
That's exactly what we wanted. So we wanted to be short. We wanted to be a little awkward. Because we want to sort of set the stage for what we're going to talk about next, and sort of how we address these things in sim and in real life as well. So, but I guess just to sort of debrief, like a mini debrief. How did that feel? Besides the awkwardness, how did it feel saying those things? How did it feel about hearing that comment?
I think that if I didn't really have a relationship with the students, I probably wouldn't have said something like that. But if they knew, if I knew the students, or I was a mentor or something like that, then maybe I would say that. But I almost don't understand why it was said, and I think that if I'm not understanding why it was said, I think that the people who are receiving that comment can really interpret it in a lot of different ways, because I felt the need to kind of explain myself afterwards, because I didn't feel like I knew why I was saying it. So I'm wondering if the receiving party felt that also.
Interesting. Okay.
Yeah, I felt confused too. I think maybe this would fall into the bucket of micro assaults. Like, it wasn't exactly like subtle. At least to me, it wasn't subtle. And those I just like feel a little bit more kind of taken aback by when they happen. It just kind of paralyzes me a bit. I'm like, okay. I struggle more with like a lot of like the different microaggressions that I call like the thinly veiled compliments that are really, really problematic. And those ones I struggle with a lot more, because.
What did you call them? The what compliments, right?
Oh, like thinly veiled compliments.
Oh,
like
yeah.
If you don't mind going back a few slides in the quotes. Oh, sorry, it's a lot of slides.
No, it's fine. We get time. Oops.
But
you're so articulate.
So he is so articulate, and then there's really that like.
It's like a backhanded compliment.
Yeah, and you get stuck between the like, oh, I think they meant to say something nice, and now I'm here to like destroy their world and tell them how it was all wrong. Or you don't look gay is again that is often thought by the person who's saying it to be a compliment, and that's problematic. And so those ones are just hard.
Or you're not like the rest of them. You're different. What are you saying there, right?
Yeah.
Do either of you or anyone in the group have any tools that they use to sort of confront this when this happens?
So I'm not sure if I was supposed to actually talk during that thing, but
whether you want to or not, yeah.
I couldn't think of anything to say, and I think that really represents how this happens in real life. In the moment, you're kind of paralyzed by such comments. I know from my personal experience, I usually just like wait, what? And I don't say anything because you want to be the nice, respectful doctor or resident that you are. And then 2 minutes later, it kind of hits you. And by that time, it kind of feels like you've lost the opportunity to respond, even if it would have been like a thoughtful, insightful response to try and nip something like that in the bud. And then you just stay mad at yourself for a little bit, and it festers. But that's kind of what I was thinking, just watching this play out, even between Jason and Ryan. I was thinking, gosh, I don't even know how to respond to that, even if we are acting it out,
Yeah.
Yeah.
Perfect. That's a perfect segue to the next part of our talk.
It actually is. Well, and that sort of talks about a little bit about this, right? Some of the pitfalls are some of the stuff can be uncomfortable. Sometimes you can have people who are disengaged or hostile. Any other things that you feel like would be sort of pitfalls for using this? And then we'll even get onto some strategies you can use.
So
no, go ahead.
The biggest challenge I have, or I guess the question I have to you all is these simulations often, I feel, get stuck in a scenario where everyone says, well, it depends, or you know, and you sort of get lost in the details, but it is also very relevant too. And so, you know, I wonder how you balance, you know, not making an hour-long simulation for something that you may not have an hour for, while also getting at the nuance sometimes that goes into what your actual response would be, because it does, I do think, depend on, you know, the relationship that you have with this person, and, you know, are you stuck in an airplane sitting next to them for a while, or are they on an elevator and they're at their floor and they're just going to leave and you're just going to move on?
Right.
And so anyway, that's the piece I struggle with, because I think it often hinders participation because people are thinking a lot about that. And it's not entirely what the point of the simulation is about, but it often will hamper people. So that's what it's about.
Yeah, totally agree. So let's talk about some intervention strategies. There's a whole lot of them, but I've got a couple of them here because I think this is the thing. The reason we didn't talk about this before we did that role play was just to talk about how hard this is. And so why it's nice to have some kind of framework that you can use to respond to them when you run into them in actual life or in role play. So here is one. So I mentioned Dr. Su's articles before. He referred to these as micro-intervention strategies for microaggressions. So the first one is making the invisible visible. So you heard that comment in the elevator. One thing someone could say is, what did you mean by that? Or you could even repeat something back to them. So wait, you're saying that you thought we'd be kicked out by now? So now you've just made it really obvious that this person said something that was not good to say. Next thing, you want to disarm that microaggression. So one thing you'd like to do is support the target of the statement. So say that you're a bystander and you see this happen, whether this is verbal or nonverbal, kind of acknowledge to whoever was the target of that something happened that didn't feel right to you. And acknowledge to the person who was the source of the microaggression, no, this wasn't right. You can just flat out disagree. Or if you can't think of anything else to say, just say something like, ouch. And then you can educate the offender a little bit. Say, well, I know you may not have meant it that way, but this hurts. That's a negative stereotype about this group. Maybe reframe it. Can you think of another reason that things might have happened that way? And as far as external validation, that's when you would report the incident, speak to someone higher up, discuss it with someone. So this module from MedEd Portal is where that scenario came from. And what I like about this is there's a few of them, but this one had sort of a mnemonic that you can use no matter which piece of the microaggression you are, whether you're the source, the recipient, or the bystander. So if you're the recipient, you are the person that the microaggression was aimed at. Oh, sorry, you're the bystander. You witnessed it. You saw this happen. So the mnemonic is arise. So one is to just show that you're aware of this, whether you say it out loud or whether it's non-verbally. Have some empathy. Well, you might not have meant to be hurtful, but what you just said really hurt. Ask, what did you mean by that? Tell them, well, I noticed that when this happened, this is how people felt. And if you don't want to say anything right then, if you're in front of a patient, if you're in front of a colleague, if you're in front of an attending, whatever, you still may want to bring this up later because you'd like to support your colleague or whoever was the target of it. So if you are the recipient of a microaggression, it can be really hard to respond because at that point you might be really angry, you might be really upset, and you have to figure out what they meant and figure out how to respond. And if you're taking care of a patient, you also might have to do that also. So the mnemonic they have for that is action. And mind you, all these steps don't have to be all done. They don't have to be in any particular order, but these are just some things to remember that can help respond to it. So, so you could ask a question. So again, what did you mean by that? Could you explain why you said that? So I noticed that you said this thing and did this thing. And impact is just how it made you feel. And then as far as next steps, if it's someone who is a colleague, a coworker, you may say, hey, let's talk about this a little more later, or send them something to read, or if it's something really bad, report it. But if you are taking care of a patient at this point, two things to remember: make sure that you're physically safe and make sure that the patient is stable, and do whatever you need to do for that. So the last piece of the triangle is the source. And if you realize that you were the source of something like this, acknowledge it, own it, admit you're wrong, get some feedback on what it was that was wrong and why, apologize, realize that even if you didn't intend to hurt someone, that the impact is that it was hurtful, and then thank them for acknowledging it. So now, this is to remind me that we're going to do another brief role play now that we have those tips.
All right, we're a little short on time, so maybe I'll just read through this really quickly.
Yeah.
And then just maybe we'll run through it that way.
I think I had what time we actually started off.
Okay, that's probably what, my ADHD probably didn't pay attention to the first part of it, so that's probably what happened.
Yeah.
So basically, this is our other case. So you have Dr. Wallace is leading a group who's advising a session on medical students that are applying to residency programs for OBGYN. As the specialty is getting more competitive, the medical students in the group are quite anxious and are discussing their worries about whether they will match up into the desired program. Maria, a Latina medical student who is first-generation college graduate, is telling the group how she applied to more residency programs than the national average because she is especially worried about not getting in to the competitive specialty. Caleb, a fellow medical student who's a white male, assured Maria that she doesn't have to worry about getting into OBGYN residency program because she is a Latina and they're short of Latinxes. So she would be sure to get in as a diversity hire. Dr. Wallace noticed that Maria and several other students in the group were looking frustrated and the tension in the room was high. Dr. Wallace didn't say anything because she was not sure how to respond. Instead, she changed the topic and moved along to interviewing techniques. So I guess from there, because we're short on time, we would have you guys play it out. Maybe we'll just, do you want to just run through the source, recipient, and bystander and see how they should respond?
Let's do it.
Okay.
Sandra, you got the stuff, right? Timing wise, I thought we were okay, but we obviously were supposed to start a few minutes earlier.
So I guess because we only have like 5 minutes left, maybe it's best if we just run through from like each perspective, their approach. So in the chat, we copied down the acronyms that we discussed in the prior slides. Someone want to take a stab at it if they were the recipient using the action approach?
I'll take a stab at it.
Sure.
I'm assuming that someone just told me that I'll get in. I shouldn't worry. So I'd ask, what do you mean by that?
Good.
I just want to know. I'm curious.
Mm-hmm.
Awesome. Absolutely.
And if say you're the source, if someone wants to be the source, and how would they sort of respond to that using the assist approach?
Sure, I'll go ahead. Oh, I'm sorry. I don't think that what I meant to say was very clear. I realize that maybe I was now I realize that I was trying to, well, now I realize that despite the fact that I was trying to talk about increasing diversity in the program, I actually may have made a microaggression towards individuals who have a Latinx identity. So again, I'm very sorry about that, but I appreciate that you brought that up to me or asked a clarifying question.
That's a hard role.
What's that? Sorry.
That's a really hard role to play out. Good job.
That's the humble one.
I guess I would maybe also add that I just meant that one of the qualities that you have that maybe some other applicants don't have is a diverse background that might add to representation in the field.
Mm-hmm.
But it didn't come off that way when I made the comment.
Yeah. I think there's a lot of power in sort of doing the intent versus impact. What you intended to say and what actually happened is important to sort of express that, especially to the recipient. And I think
someone brought up about humility. I think that's like, as like the aggressor as the source person, and I think that's like the perfect time to demonstrate humility and recognize that we may be messed up. And so it's also a good time to ask, like, how did I mess up? Like, because this is what I was trying to say, and clearly it wasn't taken that way. So it's actually not a bad time to like maybe ask, like, you know, like, well, I don't know what I said wrong. Can you help me understand why I offended you? Because there are times that we say things that we didn't realize were offensive.
Mm-hmm. And then finally, the bystander, which I think is the most common, well, it depends on who you are, but it's, we often find our times in the bystander role where we overhear things, especially in the emergency room. Does someone who hasn't gone want to try doing the ARISE approach in terms of how they would respond as a bystander?
I think everybody's talked. There's not many of us.
Okay.
If I was the bystander, I can already see the look on my face. They would probably be like, hey, that kind of wasn't cool. And I'm not quite sure like where you were going with that one. But I think Maria expressed her concern about how scared she is for applying to residency. And she's going to be a great applicant, but it was kind of like maybe you downplayed like her awesomeness based on like her background.
Yeah, these are all really great answers. And this stuff is hard, but I think sort of thinking through some of those steps can help you, whether you're the person it's directed at or whether you're just watching it happen. So just take home points we want to leave you with. One is that role play can give trainees tools to respond to racism and bias in the workplace. Another is make sure the environment's safe. Considering using some scripts when you're addressing sensitive topics, avoid racial slurs and foul language. Don't force anyone to do anything that they're really uncomfortable with, and watch and see if anyone's having a really hard time, and let people take breaks if they need it. And then finally, an important thing to do is debrief. I know we didn't debrief just now, but I think they're probably going to kick us out of this, this breakout room in a moment. So these are the references we used to make this up. Annika will be sending out the references to everyone. And then finally, does anyone have any questions, comments, feelings about this?
I really like this. I think the bystander role is really, I think the techniques for bystander role are really helpful because I can see myself being in that situation quite a bit. And so it was helpful to, you know, just kind of practice and say some of these things.
Mm-hmm. And that's why role play is so great for this, so that when that actually happens in front of you at work, you're ready with some way of responding to it.
Thank you for this.
Thank you.
Good. Enjoy the rest of your afternoon, evening, whatever it is now. Then what did she say? Who stays still? We stay still. They move. How does this go?
I think you guys are going to be rotating.
Okay.
Yeah. I don't know if you have to go back to the main room or not.
The screen changes.
It used to be automatic.
Yeah, I thought we were just supposed to sit here and something was supposed to happen. I guess we'll find out in a moment.
Maybe somebody will move you.
Okay, there we go.
All right.
The world of doing things on Zoom, man.
Yeah. It's so much easier in person, right?
Yeah, just get up and go to a different room.
Right.
I'm hopping to a different Zoom, so thank you all so much. Appreciate it.
Thanks, guys.
That was a bummer. We got
I know that was
quickly. It's fun.
sort of got zipped into the Zoom universe.
Totally.
We'll have to go back to that question. That was really good.
Sorry, I thought time was up and I was told to move everybody.
No.
No,
It's
you're
totally
totally
good.
right.
You were 100% correct. We just, it's one of those things where, all of a sudden someone's like, I just thought of something, and then they just keep
Yeah.
talking.
It's a natural problem with Zoom. I don't know how to fix it. Even if you no matter what you do, it's a problem.
Yeah, it's true. I remember during the virtual interviews, you would see the counter and you would say, okay, oh, they're going to kick us out in 30 seconds. So, we'll say our goodbyes. And if you said them too quickly, then you sat there and stared at each other for the next 20 seconds.
Or you got whisked away mid-sentence, right? I don't know. It's just awkward.
Did someone from here just leave?
I don't know.
Yes, I think there was someone that just left. Ryan, I think.
Okay. Just looking at the count, I was confused.
Yeah.
There was also someone that joined our initial room kind of late. I don't know if she joined late or.
Yeah, she joined late, so I didn't
Okay.
want to just alone in the multiverse. So.
Got it. Cool.
So we have a bit of a break now, right? So that
Yes.
people can take a breather, get a drink, do all the things that they need to do. My clock says that it's 3:44.
When are we starting again? Do you know?
Supposed to be in 1 minute.
1 minute?
Based off of the clock that was going.
That's awesome.
Okay, well, I mean, it's a small enough group. Tell us what you guys need.
I'm good to go.
You're good to go.
I'll take 2 minutes
Jason
to
and
run
Miriam,
to the bathroom.
go to the bathroom, do it.
I'm good to go. I will actually have to head off in about 15 minutes to head to my shift. So.
Oh, okay. So then we should just start, right? That way.
I'm ready. Sorry, Jason.
Well, at the beginning of it, there's a lot that we can probably advance through fairly quickly. And we learned a lot even in our first version of this in terms of figuring out our timing and the things that spark different types of conversation. So you guys met us in the overarching session. So we won't go through this in too great of detail. I'm Lisa McQueen. I'm from University of Chicago, where I run our residency and our fellowship program there in pediatric emergency medicine.
And I'm Christina Lindgren. I work at Children's National, and I am one of our associate program directors in the Emergency Medicine Fellowship.
And this session is really focusing on debriefing specifically. We were interested in thinking about how you construct cases, how you examine the cases that you already have, and then how you actually debrief with your learners around issues of DEI as you're both creating and conducting your simulations.
So we have no disclosures, it was already described. So I think we just want to be really clear that we are not by any means content experts. And actually, this is a fairly new area of research, as we all kind of know. There's a fair amount, but specifically related to simulation and specifically related to best forms of debriefing, there's really not specific evidence or literature on that. But we really want to try and make it better and improve the training environments, and hopefully you guys can help us in that process. So we talked about this a bit. And I guess the most important piece, I'm going to breeze through this a little bit, Lisa, given our last group, was just think about if there's specific scenarios based on the conversations that we have in which you could apply this work. And if anybody wants to say anything sort of upfront about their experience with debriefing simulation related to DEI, please feel free. I'll give you a minute. Okay. All right. So the goals of this really are to describe different debriefing strategies and techniques, learn how we can apply those strategies to difficult conversations, specifically both unplanned and planned, and we'll talk about that more. And then specifically apply this to debriefing, these debriefing tools to our work in diversity, equity, and inclusion. And so I think the first thing is to sort of take a step back and think about, why do we debrief at all? And so debriefing is really used as a reflective practice. It's meant to be bi-directional. It's not really meant to be feedback, but rather a conversation. So as a facilitator of simulation, you really are meant to be facilitating a conversation. And by doing this, you allow your trainees to explain and analyze and synthesize the information you provided them. And then it sticks them into that emotional state, whether it's really like a crazy trauma or a very emotional parent or patient, to improve their performance in similar situations in the future. And by sharing sort of critical judgments, whether it's between participants and or from the facilitator to the participants, that's an essential part of learning, both in simulation and debriefing. And so when I think about debriefing, I really think of it as like this either unidirectional, bidirectional from the facilitator, which I would really call the co-learner with the learners, and then also amongst the learners themselves. And so when you're doing debriefing well, it's a combination of all of this. And what's really, really important, I think, when you're thinking about topics related to diversity, equity, and inclusion, and topics that are, I guess you could say, a little bit more emotionally charged, is to really cultivate this psychological safe space. So this is a safe environment. What happens in this room stays in this room. So establish the ground rules for all participants. We're here to do our best. We're all trying to perform our best, and we're not really trying to get you, right? The goal of this is not, as opposed to others, is not to like, I think, well, you can do it one of two ways. If you're saying this is a topic related to diversity, equity, inclusion, you're going to posit that right up front. You want to be really clear about that, so it's not, they don't feel like you got them in the moment. On the other hand, if it is a topic where part of it you're weaving in diversity, equity, and inclusion, you have to be very careful not to get them in that gotcha moment. You have to be very thoughtful about not putting your learners in that place to make them feel uncomfortable. And then the basic elements of a debriefing are establishing a shared mental model with your learners. So that's sort of like one-liner of what you were trying to achieve. You want to talk about your learning objectives, ask open-ended questions, and really allow for silence, for reflection and thinking, and for them to really engage in the process. And there are these strategies that are used for debriefing that are discussed frequently. I will sort of summarize to say that it's either the learner reflects on their own, you can provide directive feedback. This is more in sort of like tasks or junior learners where it's a very clear context and there's a gap in performance. The advocacy inquiry is a really lovely model, which we'll talk about more, but it's sort of, I noticed, you advocate as a facilitator, I noticed that this happened. I'm curious as to why, what were you thinking? What was your mental process in the moment? Guided team self-correction is sort of the whole team as a whole thinks about their team as a unit and their team performance as opposed to like individuals. Then circular questions, so you could have an outside person like a nurse or someone else that could posit their opinion about what happened, and then they circle back and comment from an outside perspective. So we just wanted to, these are what exists in the literature to provide sort of a framework as we move forward in thinking about this. And the way we really want to think about this is in the setting of cases. So specifically thinking about expected cases. So I put cicadas on here because I live in DC and we're about to get bombarded by these brood X cicadas. This is expected. We know it's coming. It's going to be awful. But similarly, like if you're going to talk about DEI, you're going to tell your learners, like we're going to focus specifically on this content related to, let's say, a same-sex couple, right? Versus the unexpected, where something might come up, like you're planning to do a topic on asthma and some really horrible microaggression happens along the way and you want to debrief that. So that's the framework in which we're going to talk about this. So
So our first case is really talking about debriefing expected and planned DEI topics. So this is a model where we took an existing case that one of us had. That's a pretty straightforward case that many of us would encounter in an emergency medicine simulation resuscitation environment. So the case is a 4-month-old who is brought to the emergency department with altered mental status. And the idea behind this is taking a look at your existing cases and really thinking about not just what are the medical steps in the resuscitation and taking your learners through the medical steps of the resuscitation, but also taking them through the reflective process of why they made the decisions that they made, why they generated the differential diagnoses that they did, and kind of turning some of that reflection inward as part of the debriefing. So the case is begins with a charge nurse bringing a baby back to the code bay and stating, this is a 4-month-old who just came in, not acting right. According to her caregiver, she didn't wake up from her nap. And when she was checked, she was difficult to arouse and was breathing funny. She's not responding to my stimulation. She appears to be having some episodes of apnea. So very standard opening for a lot of emergency medicine simulation, right? So imagine the kind of initial assumptions that you make as the person beginning the resuscitation and gathering all of your initial impressions of the patient. How do these impressions, how does the scenario change based on the color of the mannequin that's presented to you? How does it change based on the name of the patient that's presented to you? Do these changes in identity as you're developing a case push you in one direction or another in your thinking, and giving your learners an opportunity to actually really think about that and talk about that. These are sort of, when you have the initial sort of case set up for your group, this is the sort of like initial identification pieces that we thought of right away. Curious to see, right, because this is, again, a conversation more than us giving you didactic content. What are the other sort of initial kind of first impression pieces of data that could actually be debriefed in this way? What do you guys imagine? The name one, I'll tell you guys, came from our own scenarios around having difficult conversations with families. We had a course that taught residents how to communicate death to a parent after a resuscitation. And there were 2 scenarios. One was in the ICU, and the other is in the emergency department. And the ICU case was a kid with complex congenital heart disease who ends up dying in the unit. And the ER case is a kid who comes in unresponsive by EMS, who has, as the case progresses, has evidence of non-accidental trauma. And the 2 cases have very stereotypical white and black names attached to them as part of the sort of case scenario. And it's really problematic, right? Because you could imagine which was attached to which scenario. And those kinds of attempts to diversify your case roster, actually reinforcing racist stereotypes, is a really important target, I think, for how we can actually change our scenarios as we're building a case series. So as the case evolves, the caregiver says, I last checked on her 30 minutes ago. She was sleeping in her crib. And these scenarios are either presented to you, depending on the sim environment where you guys work. Sometimes you just have a facilitator who's kind of giving you the next sort of pieces of information as the sim unfolds. And sometimes you have really complex scenario environments, simulation environments, where you might actually even have a standardized patient who, arrives to the trauma bay and gives you more information, right? So depending on how you set those different cases up, you could end up with really different kind of directions that the team goes, right? And so these are some that we were thinking about. How does the scenario change if when the caregivers arrive, it is a mother and a father who are really well dressed versus a boyfriend of the mother, right? Any sim scenario in pediatric emergency medicine, the minute somebody says it's the mother's boyfriend, everybody jumps to child abuse, right? Like that's supposed to be your like diagnostic clue. What happens when the caregivers are not Caucasian? What happens when they appear disheveled? Do you come up with a different approach or differential diagnosis if you have a same-sex couple versus a heteronormative couple? All of those different identities really do potentially change how your team thinks and operates. And how does the scenario change if you have a baby who is told was sleeping on a crib, in a crib versus sleeping on a couch as part of the STEM? And this really gets to some of what we've been talking about as we expand simulation scenarios to think about diversity and diversifying our scenarios. Being really cautious about how we use those identities. And this comes up on the next slide, to avoid actually reinforcing stereotypes. Because I think we all do this, right? When your team, especially when your team is kind of struggling, right? You know what they're supposed to do next is intubate the patient, and they're not recognizing they're supposed to intubate the patient. And so you make the SATs drop, more precipitously, or, you give them a clue, right? Knowing, and our learners expect that from us. They expect that when we tell them a piece of data, that it is somehow meaningful. We have to be cautious about how we use that expectation and keep that from reinforcing bias and stereotypes. And this actually is a really nice paper that looks at not SIM specific teaching cases, but medical education teaching cases at large. And we wanted to share it with you because we think there's a lot of applicability in simulation as well. So what this group did was they examined a huge range, something like 63 of these virtual teaching cases, and looked at how race and culture were built into the cases. And then generated a series of or collection of pitfalls in applying this type of lens, and also then what to do differently. So some of the pitfalls that they identified, one was using race as an identifier as a sort of genetic code for something rather than a social construct. The second was linking these identifiers to personal behaviors rather than to the social environment or the political environment, so that it became meaningful that a person's ethnicity, somebody behaves this way because of their ethnicity as opposed to because of something in the local environment. And in the process, reinforcing inadvertent stereotypes. So that is the piece that as you diversify a simulation, set of cases, you have to be very cautious to guard against. Futility as a pitfall is this idea that, they use an example of a homeless person who has no place to go, and therefore you have to make some other kind of decision because that identity is sort of linked to an inevitable outcome. Having any of these cases without any reflection, and assuming that that the default is white, and therefore if you identify race or ethnicity in your STEM, that is somehow supposed to be a meaningful kind of trigger for you to think about something in specific. And so what they've done is generated some strategies to help us in rebuilding these cases. And we think that they're pretty useful for rebuilding SIM cases, right? So one is, do not assume that the minoritized patient is the other. What is the reason that when you buy a mannequin for your sim center that you buy a white-skinned mannequin? Why shouldn't we all just buy the African American skin mannequin as our default, right? Like the idea that that the minoritized patient is automatically otherized. Avoiding racial identity as the diagnostic clue, right? So if you, in these cases, they talked about, don't always make your African-American patient have sickle cell disease, right? Have that patient have, leukemia or, any number of other diseases, right? So that the racial identity doesn't become the diagnostic clue. And be cautious with teaching, especially around cultural competence, that you're not teaching stereotypes as a shortcut for teaching cultural competence, right? And I really hate that term cultural competence because it implies that, like, oh, you should just learn, these features of each of these groups, and therefore you can then navigate all of those different spaces. And in fact, I think the cultural humility that one of our participants described in the larger opening session, I think is a much better way of thinking about it. They have suggested offering different images as part of the sort of roster of cases, and we would just switch that to mannequins. And then in all of this, right, whenever you're talking about different health outcomes based on race or gender, ethnicity, back it up with evidence, right? There is evidence out there, and you can talk about that evidence so that it is as rigorous as any other medical or scientific case that we do.
Any thoughts about all of that before we move on? Okay.
So the case continues. The bedside nurse hooks the baby up to the monitor, says, I can't get an IV. Her heart rate's in the 80s. I can't feel a pulse. The team starts CPR, places an IO, and prepares for intubation. And the resident examines the patient and states the pupils are fixed and dilated. There are good bilateral breath sounds with bag valve mask ventilation. The abdomen is soft. There are 1+ femoral pulses with CPR, no deformities to the extremities. And at this point, you prompt the team to consider a differential diagnosis, right, and next steps. So they are actively resuscitating. And here's another reflection point. How might the team anchor based on the case that's presented? Non-accidental trauma versus sudden infant death versus primary respiratory failure leading to the arrest. And this is where, you can really use some of these debriefing strategies that Christina had summarized early on to kind of get your learners to think about some of the diagnostic reasoning processes that they're using and the ways in which assumptions can actually kind of push them in one direction or another. And some of these are more amenable to this kind of case than others, right? And really a lot of the sort of like the directive feedback that you could use if you're trying to get somebody to, deepen their compressions during CPR, much harder to apply for this kind of conversation, right? And in fact, probably not a good idea at all to apply in this sort of conversation.
It also depends a little bit on your focus, right? So if you're really using this, the medicine for you in this scenario might be a little bit secondary, which I think, we're always taught to think of simulation sort of like on a checklist and completing outcomes. But for you, really, this is more like prompting a conversation potentially. And so, it's how you approach the teaching, sometimes like flipping the script a little bit and being like, what if this were X, right? Like, how would you consider if the patient presented this way? Or you could posit some of those reflection pieces in your debriefing to encourage that sort of questioning,
I think this is a really interesting way of going through a case with learners. Dr. McQueen, I'm in Chicago, and our residents rotate between Swedish Hospital in Lincoln Square and St. Bernard's in Englewood. And for those of you on this that don't know, St. Bernard's is on the south side of Chicago, and our patient population there is 99% Black patients. And I think that my residents would approach a case differently depending on the location of the simulation. Like if I said our patient is presenting at our Southside Chicago hospital versus our Northside hospital, I think the differential would change drastically for a case like this. So what a great way to even explore that potential bias.
And again, it's really not to, I think we sort of talked about this a little in the last group, like if we want to change the culture of medicine and sort of really prompt people to think about their own implicit biases, a lot of it is reflecting in a safe space, which is simulation, right? So reflecting when you have the safe space to have these conversations and it's not real life, you know? So I think that that does give them some liberty to have those conversations.
I guess the one question I have, I think this is fantastic, and I could see how easy it would be to make assumptions about the presenting people based on their background or their certainly their physical appearance or obviously race or anything like that. How do you draw the line between being thoughtful about a patient's access to care, let's say in a urban hospital, regardless of the race, versus a suburban hospital where you know the majority of the patients have, you know, primary care and insurance and affluence? So how do you appear as an advocate for you know, health inequities by considering less access to care and all the things that come with that, and not make that look like you're assuming that, you know, someone is poor or of X race and therefore doesn't have care, you know?
Yeah, I think you've hit upon a really important question and a really challenging problem, because, you know, to build it into sim, right? Like we use all kinds of shortcuts all the time in simulation, right? And what you're describing requires a much more nuanced conversation. And I think that's where the debriefing really becomes critical, because then you've opened up a space for people to talk about that in a much more sort of reflective way. And I think that, you know, the group that did the medical cases review and suggestions, that was one of their sort of big observations as well, right? Is when you're talking about folks who don't have access to care or have limited access to care, that you frame what happens in that medical case as a consequence of that access to care rather than as a consequence of their behaviors, right? And there's ways that we do that all the time when we describe something, right? When you describe a patient as non-compliant, or, you know, they've missed all these appointments, you know, you could imagine, right, a kid who presents in severe DKA, and you could describe them as having missed all their appointments and, you know, their parent not giving them insulin appropriately versus, you know, having been cut off from their insurance and, you know, unable to get the insulin, right? It's you can set up the conditions that
Based on the verbiage and
yeah. And you can, you know, even, and this is just me kind of spitballing, right? You know, we did for a while, before COVID, we were using standardized patients as part of our SIMs, and we would use them, you know, as part of how they got information from the case, right? So, you know, the initial information might seem one way, but then the standardized patient comes in and gives you another piece of information, and you can actually let them be the ones who kind of deepen that knowledge, so that your whole team says, oh, wow, I thought one thing, but it actually turned out to be something else. And that helps me think next time, right? I'm not going to make this assumption.
Along those lines, I wonder if it would be interesting to set up our residents to be in a position where they have some preconceived bias, or, you know, we set up a sickle cell patient in an urban hospital, which maybe would lend itself to some preconceived bias, and then in the case have them pull out that information that actually goes against the biases that they have. I wonder if that would be either an appropriate or effective teaching strategy.
Yeah, and I feel like ultimately it goes back to like, why does it matter, right? And it's because there's health inequity, right? Like people get different care based on those basic assumptions. And so I think it could be as simple as like pointing out, you jump to this, and I wouldn't be this direct, but like, I'm curious as to why you landed on this sort of path without broadening your differential sooner, you know, and that might be based on like assumptions, which are helpful because you're trying to arrive at the diagnosis quickly, but it can also lead you into creating problems and making mistakes and missing things, right?
And this is where you could actually use that guided team self-correction really effectively, because then it's not that an individual person made an assumption, but that the entire team kind of went along down this diagnostic pathway and then realized, oh, right, this was completely different, right? And we made assumptions that led us down the wrong pathway. And having the team figure that out as part of the sim is a really good way of getting, I think, to that realization without having it be one person feeling like a target, you know?
Yeah.
So let's forward to our next, any other thoughts before we move on? Actually, we have like 17 minutes left, so this is a shorter piece.
Yeah, this one is straightforward in a very different sort of way, but I think in some ways really hard. So this is a case, I don't know if either of you are PALS instructors, but you know, this is certainly really familiar to me. You know, those PALS mega codes that you put everybody through in order to get their final certification. In this case, you're the PALS instructor, and your job is to certify the group that you've just been teaching for their final certification. That they're running the mega codes. Each of them is supposed to run at least one of the codes, and there's 4 participants in your scenario: Kate, Mike, John, and Noah. And as they go through the mega codes, you notice that each time that Kate is the team leader, the team dismisses her. They're slower to enact her orders. They do things that she didn't actually ask them to do, and really just don't respond to her as the co-team leader. Whereas when the other 3 lead, they are sort of taken at face value as the leaders in a much more sort of deliberate way. And in the middle of a scenario, as they're switching between cases, one of the participants, Mike, makes a joke saying, "I hope I don't kill him this time," or should I say Pat? I mean, with the ambiguous genitalia, who knows? So, you know, this is the paper that Mike referenced during the initial opening session. And so I won't belabor all of the details, but you guys remember it was that rudeness in resuscitation papers. They took different scenarios and had teams actually run through complicated neonatal resuscitation. And some of the teams were exposed to a parent who makes, you know, a pretty obnoxious comment, whereas the others are not. And independently blinded observers scored the team performance, and the teams that were exposed to those rude comments actually performed worse medically. And like they were slower to intubate, they didn't communicate as well. The actual medical resuscitation steps were not as strong. So this is, I think, an important observation. It does actually matter when people experience and say these types of things in our patient care scenarios, right? It changes the care that people are able to deliver, which I think is a really important insight, because then it kind of pushes us to think, well, what is our role then when you are the instructor in this PALS scenario and this happens right before your very eyes? And it wasn't intended, and you didn't have a pre-brief about it, and people just came in expecting to do their PALS recertification, right? It's not, this was not supposed to go this way. What do you do as the instructor?
this is
And
a
we asked you because we don't know.
Yeah, this is such a hard situation because we are constantly inundated with rude comments in the emergency department, you know, whether it is related to your race, gender, or anything personal, or, you know, just the environment that the patient is in or the care that you're providing. I mean, this is just a constant barrage, it feels like. And I'm glad that there's literature published about it, because you can see, you know, I can just think about myself and how I've felt when confronted with these, you know, these types of rude comments, and how much less it makes you want to provide care for the person that's in front of you.
And I think it's hard in the clinical environment. I think that's why it's even more important to practice in a lower stakes scenario. I think it's particularly hard when it's the patient towards you as the provider.
Yeah.
I think, right? Because of the patient experience and everything else that goes into that. But I think when you're seeing it between colleagues or from like someone, so like in this scenario, I think you wouldn't necessarily expect it per se.
True. Yeah, no, you're right.
And so, I mean, what do you guys think? Do you think like, is it our role as debriefers or facilitators of debriefing to?
Can you go back one slide?
Yeah.
Oh, sorry. Yeah, to the case.
So it's this mega code.
Right here. So when I was initially reading this, I didn't even get past that first bullet point where Kate, who I assume identifies as a female, is writing the code and dismisses her and proceeds on their own. And that's literally something I'm getting into in terms of my research, you know, like exploring like inter-resident gender bias. So it hits home for me perfectly. So I've been thinking about how I would address this, because, you know, I'm a female physician, and obviously I run into this all the time, as I'm sure my members do. And I think up until a month ago, I honestly wouldn't have felt empowered to address something like that going on, just because of I'm kind of the mindset where I pick my battles, which I know is not a great excuse, but I mean, it comes down to that sometimes. It depends on your objectives. And if I'm just trying to teach something or get through a code myself, I'm trying to pick what I'm going to take a stand on. And sometimes it's not worth the emotional energy to go through something like that. But now that I'm getting into this, I feel incredibly empowered, and I'm hoping to feel more and more empowered. And I think I would try to say something. I have no idea what. I haven't figured that out yet. And I think that's something I'm going to try to develop this in the next year, objectifying what makes it so difficult for certain people to lead code successfully, you know, independent of outcomes of the patient or whatever, more just the actual success and leadership of the code or resuscitation. And if we can identify some of those things where there's a difference between, where there's a gender difference, and see what factors are causing that success of the resuscitation, then maybe we can learn to address it and figure out how to address it. Yeah, short answer, I don't know how to address it.
So I think that's such an interesting comment, because I have the same reaction to the second bullet. So I became very much a feminist and pro-women when I had 2 daughters. I wouldn't have considered myself that beforehand. And so now I have no problem advocating for Kate in this situation, or even calling some of the team out on, it seems like you're more hesitant to carry out the orders when Kate's giving them. Why is that type of question? And then in the second scenario, I find myself maybe less able to recognize that it's a problem, and even less comfortable addressing it, and sort of picking my battle and just kind of letting it go.
Interesting. I like how you framed your initial response, Jason, for that first bullet, because it might actually give a little bit of a script, I think, for what you can say in a moment like that, right? And it's exactly that advocacy inquiry model, right? I noticed this, what were you thinking, right? And it may even be, right, who knows who these people are, right? And they may be people you have a relationship with, and they may be people that you don't. And that also changes how you might do this communication, right? Because, pals can be, like in my hospital, like we'll do pals and they'll be like random nurses from, some other building that I've never met in my life, right? Versus if it's my own residence, right? Really different dynamic. But that advocacy inquiry allows you to point something out that they didn't necessarily see, but then have them reflect on it, right? So I noticed when Kate ran the code, you didn't actually follow her instructions, but when Mike did, you did follow his instructions. Did you notice that? What was going through your head? What do you think? Why did that happen?
Yeah.
And I imagine that it might land differently if it comes from a female instructor versus a male instructor, depending on what you're pointing out too, right? There's all sorts of variables that are really complicated here.
I also think the thing that's hard is like, you don't want to make Kate's just like a roll with it person that it won't even matter. Or maybe it will actually really affect her self-esteem and like she won't think she's good at running resuscitations, like that whole, it was kind of rude. But it's hard when you don't have a relationship with the people to acknowledge whether or not they could potentially be affected by the moment and whether or not it does reinforce potential trauma for that person. And there's no way to know that, right? That's like one of the things that I think is the hardest part about this topic in simulation and debriefing. And is like everybody walks into the room with their own experience and their own, like whatever they're bringing into the room. And we may or may not know that, right? And so I think that's why acknowledging a psychological safe space is so important. But I think when something like this happens, it kind of breaks that down a little bit, right? Because you're like, okay, I thought this was a safe space and we're being kind. Then something like that happens. And maybe so-and-so's actually doesn't equate with being male, or maybe they're a they, and like all of a sudden now, but nobody else knows that, right? And so it's kind of challenging in that way.
Well, and I think you said it in another version of this conversation, Christina, that like the idea of safe space is much more complicated when we're talking about this stuff, right? Because we grow when we become uncomfortable. So being in a safe space doesn't mean you're free from any discomfort. It just means that we won't attach judgment to that discomfort. And we all presume that we're all just trying to get better,
That's why I was just going to say that being in a safe space, it doesn't necessarily mean that you're going to like everything that's being said, but that you do have to respect that it's being said.
The other thing we've talked about a bit amongst ourselves and then amongst our larger group is like, it also depends on your practice environment, right? And so if you're going to focus, for example, on something focusing on like a minority and there's only one minority in the room, that might be really challenging as opposed to like a room where half of the people are minorities, and or depending on where you are in the country, certain topics are more open for discussion, right? So that definitely introduces another element that makes it challenging.
I saw our banner pop up that we only have 5 minutes left.
So we were just sort of focusing on like some of these, really highlighting that this whole advocacy inquiry is really important in this scenario. And as a facilitator of simulation, really like, this is hard. This is really pushing yourself beyond your comfort zone, right? Like your safe space, but really challenge yourself to do this. And then we sort of just pose these two questions, like how do you debrief with learners who enact microaggressions? We sort of talked about this while maintaining the safe space. And then also the other thing is, what do you do when you notice based on something that one of your learners just immediately sort of withdraws or becomes angry? Like it could be either, and how do you debrief that, Have either of you ever come across that?
I've certainly been an observer to this, a situation where a facilitator or the person running the simulation, I think they were doing rapid cycle debriefing and with a nurse, and the nurse felt targeted maybe, but probably was just like unfamiliar with what was occurring, what type of coaching was occurring, and probably felt a little targeted and immediately withdrew from the simulation and looked a little sad. And my response as someone that's learning how to facilitate simulation was to just say good job. I didn't want to confront her about it necessarily and make her feel like she had to talk about it, but that was my initial response. Just like, hey, I noticed that you struggled with this, but you learned it. Good job. That was great. Well done. We'll see you again next time, hopefully. Try to make it brief and say I'm here if you want to talk about anything else.
I think the pre-briefing part maybe helps with this debriefing aspect, or maybe it helps to avoid some of the person, being angry and uncomfortable or feeling targeted. But it's really challenging, and I think it's all centered around sort of the the thoughts about what it means to be racist or prejudiced and carry out those acts. Those are all very negative terms, and I think that if someone does something that is perceived as racist, they think that it is personally insulting to them, and makes them look like a bad person, as opposed to it being a learning opportunity and how to sort of grow from that. It feels like a personal attack if you are to point out that someone does something like that. And so I don't know how to frame that differently. I was having this conversation with my dad, who's very traditional in so many ways, and the whole conversation, I felt like he thought I was attacking him, and I was really trying to I felt myself trying to like diffuse the situation the whole time, trying to frame racism and prejudice in like a very different light. So I think if you can do that and recognize like this is a product of our society and our upbringing, and we're trying to remove some of it from medicine and from exacerbating health disparities, that maybe you can avoid the angry person. I don't know.
Yeah, that would be interesting to study, actually.
Yeah.
Like how your pre-briefing on this topic affects briefing.
Affects the debrief, yeah.
And I think, some of this also, I think reinforces how a big culture change is going to require lots and lots and lots of these, right? It's not going to be a single simulation that is like the magic bullet, and so just kind of that ongoing conversation and whether you can actually have an ongoing relationship with your learners, right? They're probably the expected planned DEI scenarios are best conducted with people that you can have ongoing relationships and communication with, as opposed to like this one-time event. Yeah. So I'm seeing the banner that we're supposed to be finishing up now.
Thank you very much. Appreciate it.
It's been a great conversation. Really appreciate it.
So much.
hello to both of you. I actually am familiar with both of you because of prior work. So, but Jerome may not be. Maybe go ahead and say hello, just so we kind of have a background of who you're usually teaching. Maybe Sonia can go first.
Sure. Hi. I actually have talked to.
Oh, that's right. You have talked to Jerome. Never mind.
Yep.
But yeah, I'm Sonia. I don't know if Jason got the whole intro, but I'm a PGY4 in Chicago, and I'm about to start my simulation fellowship in Chicago as well.
Awesome.
I'm Jason. I'm one of the associate program directors in Rochester, New York at Strong. And so I'm mostly working with residents, and then I also teach some medical students as well.
Excellent. Awesome. So this session is labeled as, I think, bias group or something similar. That's not what we're talking about. We're actually addressing a case and giving an example of a case that we wrote for our residents that addresses transgender health and gender affirming care, and gives our residents the opportunity to practice some of the very important kind of basics of gender affirming care within the confines of a simulated environment, so that they can take that with them and practice gender affirming care in their patients, with their patients. What we'll do is we'll start by watching a video of the case, which I inadvertently closed last time when it was making noise. So I'm going to have to find that for a second. And then we'll share the text that we used for the communication cases, so that you can kind of take a look at how that video happened based on the text that we wrote for the resident and the faculty member. The other reason that we have sought to create this faculty resource guide per se is because, due to budget constraints, we are not quite able to afford standardized patients for all of our communication cases, but our faculty are eager to teach and very willing to teach communication skills to our residents. So in that setting, we have available faculty that may have limited experiences with transgender health, but may be willing to try and teach the case if we give them the right resources. So we've compiled several resources in order to provide faculty with that background, that they may feel more prepared to lead the case, even in the setting of limited resources and limited prior experiences. So we'll get into a little bit later kind of a discussion about what types of faculty or standardized patient resources might also be helpful in this type of a case, because a lot of different places have different opportunities. So that'll be one of the things that we talk about. If you're interested or willing, one of the things that we have challenged our other small groups to do is to portray one or both of the patient or the resident in this case that you're about to see. So consider whether that's something that you are interested in, as I, for 1 second, find this YouTube. Give me just a second. All right, I'm going to go ahead and share my screen.
Hello, and welcome to our educational video for faculty interested in working to practice diversity in resident education for your own residency programs. We're going to demonstrate how faculty with some experience in simulation can work together to portray patients from diverse communities, specifically in this video, the transgender community, by way of allowing our residents to practice this important skill of communication. So after we finish, we'll get some advice from an expert in transgender medicine, and we'll be able to hear from them about how we could improve what we're doing. We haven't practiced a lot on purpose so that we can have some really formative feedback and improve ourselves, and allow all of you to see the ways that anybody who's kind of novice at this could improve their performance. The first thing that we'll do, oh, and by way of introduction, I'm Sarah Hawk. I'm a simulation faculty and emergency medicine physician.
My name is Jerome Martin, also an emergency medicine physician and simulation faculty working with Dr. Hawk.
And today we'll be doing 2 cases. What I'll start with is the pre-brief that I would usually share with my residents before we get started, which is that today we have some unique cases that are a little bit different than your usual communication cases that you might practice. Today we'll be focusing on communications with diverse populations, specifically our transgender population, and practicing some really important skills that are sometimes difficult, and we might experience challenges while we're practicing. So as a reminder, anytime you're in simulation, we try and make this a safe space to work with each other and learn from each other to make sure we provide the best care to our patients. And so when you're here, please remember the Vegas rule: what happens in sim stays in sim. That means that while you're here, be sure to take the lessons and move forward with them in the clinical environment, but we won't talk about who made which mistakes later on. We'll do our best to portray the patients in a way that will help you learn, but we may make mistakes too, so we'll work together to learn at the same time. So we appreciate your patience, and we're going to go ahead and get started with the cases.
And just to clarify, I'll be taking on the role of the resident during these series of cases, and Dr. Hawk will be taking the role of the faculty member. All right. Hi, my name is Dr. Martin. How are you doing today?
I'm doing okay. It feels so great, so I had to come in and get checked out.
I can imagine. No one wants me to ER, so let's kind of get down to it. Question for you. So I did notice in the system that that you go by pronouns. What pronoun do you use? I just want to confirm.
Yeah, I go by they, them.
They, them. Okay, excellent. And then your preferred name is Xavier, correct?
Yes.
Okay, excellent.
Yeah, it'll say like Joanna in the chart, but Xavier, please.
Okay, perfect. Not a problem. We can do that for you. So let's go ahead and ask some questions. So I know you're coming in with some abdominal pain. Is that correct?
Yeah, it's been 3 days of pretty bad lower abdominal pain, a little bit of crampiness and nausea. And honestly, there's like a fair amount of discharge down there. So I was like, I just have to go
there. Okay, excellent. I noticed you said there's a fair amount of discharge down there. So just to clarify, I do want to kind of go through an organ inventory with you just to kind of make sure that we're all on the same page. Okay. So do you still have your ovaries, uterus, and vagina?
Yes, yeah, I have everything that I was born with.
Okay, excellent. And you haven't had any top surgery or anything like that, so haven't had a vasectomy or anything like that currently?
No.
Okay, perfect.
Yeah, I'm not really no, I haven't.
Perfect. Are you on any hormones at all?
No.
No? Okay, excellent. And then do you currently have an IUD or are you on some type of birth control?
Yes, I have an IUD.
Okay, excellent. Are you sexually active right now?
Yeah, with my boyfriend.
With your boyfriend, okay.
Yeah.
And just to clarify with your boyfriend, are you guys having like penetrative sex, like with a penis and vagina, or just objects or anything like that?
Yeah.
Okay. And then in terms of your discharge, what color is the discharge that you're having?
Like whitish yellow.
And how long has it been going on for?
Too much of it. So, I guess I started noticing the discharge about a week ago, but it got really bad 3 days ago.
Okay. Excellent. So I think it's going to be important for us to do a good physical exam for you this time.
Okay.
I'm going to have to do a pelvic exam. Are you okay with us doing a pelvic examination today?
Yes, I need it.
Okay, excellent. And then we'll go ahead and feel the abdomen and check and see if you have any like pain there. We're going to make sure you don't have urinary tract infection. But the biggest thing I want to be concerned about is make sure you don't have like what we call pelvic inflammatory disease. Okay.
Oh yeah, I've heard about that. That sounds bad.
All right, we'll do that. All right. Thank you.
All right.
All right. So that's it.
All right, so that is an example of the type of case we would have our residents participate in. And I'll go ahead and share the case in a second, but any thoughts on how your residents that you usually teach or your medical students might respond to a case like that?
I think that they would be uncomfortable asking about an organ inventory. It's something that it's relatively new terminology to to myself and to our residents. I had just had a talk in our residency about care for the transgender community, and asked specifically what kind of language to use, and that term came up. So I was really glad to hear it in the simulation. But I think it's still an uncomfortable situation for the residents to be in because it's such a small population. So we don't get to use the language over and over again. So it doesn't come out fluently and you feel awkward asking it. I noticed, and Jerome, for the most part, I thought did a really great job keeping everything sort of non-judgmental and pretty positive, actually, even when talking about a serious thing. And your common response was excellent. And I think for the most part, that was a really appropriate response. But there was one time where I felt like you had asked about, you said the organ inventory thing, and then you had asked about surgeries. And then Sarah had said, "Oh no, I haven't had any type of surgeries or anything." And then you responded excellent again. And then I was thinking, does he just mean excellent that he got like the information, or that she hadn't actually had or that they hadn't actually had the surgery yet, or what? So I think even in that situation, it's really hard to say the right thing all the time.
Good, and you're actually right. It's so actually you're not the only person that mentioned that. So in another person's comment, they're also like, yeah, like that can kind of come off badly in some patients, because like, oh, like it's great that you didn't have surgery. You know, in terms of that. It's actually interesting because like it's partially a almost like a nervous tick thing, like how people say like. But then it's also actually, so when we actually did this case, we purposely actually didn't practice it. So this is actually the first time both of us are actually doing the case. Because it's funny, we wrote the case, but we weren't even in the room when the residents did the case, which is actually partially purposeful. So in that way, when we do the recording, it's literally like the pure first version, and then we're also supposed to have some mistakes, kind of. So that for our second portion of this, when we have our expert kind of critiquing the video, all those things I think are important in the conversation about, you know, watching that stuff, body language, those kind of things. It's really important.
I noticed the similar thing, and I just quickly thought I do the same thing when I'm getting my history. I say, okay, great, okay, good, excellent. It's definitely just I mean, it's natural to say that language, but then how do we train ourselves to sort of maybe consider that might be not the best thing to say, or maybe a little inappropriate in that setting? It's an interesting.
Yeah, it's definitely our way of showing that we're engaged in the conversation. And then sometimes the canned response that we have comes off as being as not having the appropriate meaning behind it.
Yeah, for sure. And you know, it's one of the challenges with this case overall is trying to make sure that the resident has like some specific goals to focus on, and also has a chance to make some of those natural kind of errors that we wouldn't pick up on in, you know, general discussion with them about what do you say, and how would you say it. So hopefully this gave our residents that opportunity as well. So I'd actually like to show the case. So I did share it there, and then I'm going to go ahead and switch to this tab. So you now have kind of the whole text of the case. And you can see how we've structured this case, which is really kind of a follow-on from all of the different communication cases that we've done in the past several years, with a range of topics, including early pregnancy, bleeding and concerns, non-accidental trauma concerns, difficult consultants, medical complications like hypoxia or hypopnea during sedation, an anaphylactic contrast reaction. So kind of the goals of each of these is to discuss a specific thing with your patient and try and use the right words to maintain a therapeutic relationship with your patient. So overall, this case was similar in format in that our specific goals for the resident were here. You know, take an HPI, very clearly showing, you know, these are the pronouns the patient uses both here and here, and their preferred name here and here. This case didn't hide those things on purpose, because one of the most challenging things is to step into a room and accidentally use the wrong pronouns or accidentally use the wrong name in a way that offends your patient and starts you out on really the wrong foot. So our goal here was actually to make it so obvious what the right way is to address the patient, that the only thing the resident has to worry about is the actual words they use to make the sentence, which in itself for residents, especially beginner residents that haven't tried this often, is challenging. But for some of us that have maybe encountered more patients that are transgender, may not feel that hard. And it may be, oh man, we want to make this harder. We want to make it a bigger challenge. We want to make there be more parts to this. But even a resident that does this well can benefit from small tweaks like, hey, your affirming statement of excellence might be replaced by something else, you know? And so giving them such a focused, such a narrow focus then helps them practice the thing that you actually want them to practice, which here is building a therapeutic relationship and then taking an organ inventory. The faculty portion of the case, and this is where it kind of gets into understanding how to prepare either yourself, if you might be this person portraying the patient, or a fellow faculty member that might be volunteering to come to your sim day and teach your residents to portray this patient accurately. What resources might that faculty member need? First of all, they might need some examples of things to say. Again, we're not hiding the diagnosis to the case. The actual diagnosis is not the important part of this case. The conversation is the important part. And one of the ways, I think Jerome mentioned that our colleague, who's an expert in transgender and gender studies, has offered us some revisions for this case. And one of them was specifically about how to advise faculty portraying the patient about how their responses may differ. So for example, a cis man portraying this patient should probably report hormone use starting several years ago, whereas a cis woman portraying this patient as a non-binary patient should report a lack of hormone use. It's a reasonable kind of way to think about how you might portray yourself. One of the things I forgot to mention in our other groups, I'm not sure where we wrote it, but the advice to dress as you would usually appear when you're coming to the simulated environment to portray this patient. We found that it might possibly, unfortunately, reinforce stereotypes about the transgender community if our faculty were to try and dress the way they thought a transgender patient might dress. And instead, appearing as I am here is a little bit of an easier way to normalize and respectfully discuss our transgender patients, if that makes sense. I could swear we put it in the case, Jerome. Didn't we do it?
We didn't write it in yet. It's going to be in the final version of the manuscript.
That very much makes sense, though.
Yeah, definitely.
A couple of other, details like junior residents may ask about plans for surgery, which technically isn't like a relevant question under these circumstances. And so the patient might say like, oh, not really, or like, why do you need to know that? Because it's really more of an invasive question than is appropriate in this setting. And so reinforcing following the case that this is an important, like the organ inventory is important for making sure you're treating the patient correctly, but like future plans for surgery is kind of none of your business. And kind of making sure you make a distinction between I'm asking this question for a medical reason and I'm asking this question because I'm really just curious. And so trying to discourage that second type of question from the residents. All right. So, I wanted to share the resources on the last page because as we're considering preparing for this, one of the ways that we might need to review, and I certainly needed to review, was with vocabulary and how to think about which vocabulary terms I might use as the person portraying the patient. So thinking of like which terms are relevant, I'm sharing, right? Yeah. So like I learned the term when I was writing this case, top surgery. And I learned that it's a common colloquial phrase that helps me explain what I'm asking about in many fewer words. I learned more about how to talk about gender affirming things, and specifically gender neutral. I wonder where, I also learned gender neutral terms, but I don't think it's on this page, such as a patient that has a uterus. In a patient that has a uterus, we're worried about PID as like a way to speak, which might not be something that our residents are very familiar with. But familiarizing ourselves with it prior to teaching this case is just similar to the way I might review the hematology oncology topics related to leukostasis crisis in acute leukemia before I teach that sim case. So it's a type of background reading that hopefully these resources give some light to. Specifically, this lessons from a transgender patient for healthcare professionals was really a nice way to think about kind of the way transgender experience is in the medical world. For example, like this lesson 2, humility can be a source of relief to an anxious patient. Basically saying, I've never worked with someone who's transgender, but I'm willing to learn, at least allows that opportunity for both people in the conversation to be open. So these things are potentially worth a read in proximity to considering playing this portraying this patient. We have, did they just say 10 minutes?
Yep, 10 more minutes.
Okay. Do you want to watch the second case, Jerome, and then potentially?
Yeah, so let's actually show the second case, and then we may be able to see if you guys can practice one of these cases. But first, we'll watch the second case and see what kind of time we have.
The second case will be me taking on the role of the attending during the communication. Hey, did you see that patient in room 20?
Yeah, I did. She goes by Xavier. So they go by Xavier, actually. My bad, I said she. Their preferred pronouns are they, them, theirs. Okay. So I just want to, make sure I keep it straight in my head. It's kind of tough sometimes.
Okay.
So they're a 20-year-old female coming essentially with lower abdominal pain and some vaginal discharge.
Okay.
The discharge is about yellowish, whitish, been going on for about the same amount of time. some discomfort during intercourse. I did do a pelvic exam while I was in the room, and there was some significant amount of discharge coming from down there.
Sure.
Kind of like that yellowish white I talked about. Definitely some cervical motion tenderness. I think they probably have pelvic inflammatory disease.
Sure.
So I did speak to them about essentially just go ahead and starting antibiotics. So I did put in the order already.
Does she have risk factors for STIs? Like, is she concerned?
Yes. So they are currently sexually active.
Okay.
They have a boyfriend and they have penetrative sex, so penis and vagina.
Yeah.
So yeah, there is definitely some concern essentially for pelvic inflammatory disease for them.
Okay.
Yeah.
Gotcha. All right. Well, I'll go see her in a second. I'm just gonna take care of something across the hall, and then I'll.
All right. Sounds good. I would say though, like I noticed you did say like she. I made that mistake too. So I've been trying my really, really hardest best to keep with the they them figures.
Okay.
Kind of as we're kind of talking about the patient.
Yeah, it's just like right here. So I was trying, but not I guess that hard. So.
Yeah, sometimes it's kind of hard to kind of keep the mind like focused on that.
Yeah.
But I was recently reading about just like some articles essentially about transgender care. And I did notice that actually like really sticking to the pronouns and practicing good gender affirming care and environments actually does improve the care that happens to transgender patients.
There's no way. I'll probably have to read that article. Thanks.
Yeah, no problem.
Okay.
All right. Yeah.
All right. If we're really done in 2 minutes, we might not have enough time to do a.
I don't think so. Probably
Yeah.
not.
I feel
No,
like we
yeah, we
switched
probably
at
wouldn't have enough
4:30.
time. Yeah, but I think they actually moved it to 40 minutes. I don't know. They say 45, but I think they're actually going to 40 minutes is I think what happened. That's okay. What do you guys think about this portion of the case? So as you can see, it's a little bit different. The goal of this case, similar to the other one, it had its own specific objectives, but the objectives for this one was presenting the patient to an attending and essentially utilizing the they, them, theirs pronouns. The other part of it actually, which can you share again to the prompt so you can see? But the other portion of this, right? So in the resident prompt, it's just you're presenting using they, them, theirs. But on the attending side, the little portion of it that they're not initially seeing is that for the attending or the instructor, they're actually purposely supposed to mess up the pronouns so that the residents may feel empowered to correct the misuse of pronouns in this case. Part of this is actually in our reading about gender affirming care and essentially making sure that we create these environments that allows transgender patients to feel more comfortable. That it's actually very important for us to use the same terms both outside the room and in the room, because it's a lot harder a lot of times to make to continue to use the pronouns when we're not visually interacting with the patient. But I have found that actually the care that the patients feel actually does change, and they feel like they're way more empowered and they feel a lot better about their care when it happens throughout. And also you're less likely to make the mistakes when you walk back in the room if you're kind of keeping it straight as well.
And she did just clarify we have 15 more minutes.
Oh, do we really?
Yeah.
Oh, that's weird. Okay, cool.
So plenty of time.
So I guess we can give the sample.
If either of you are interested or willing, Jerome or I could also play the patient or play the resident. But if this is something that you think you might want to try, and encourage you to attempt portraying the patient as the faculty member for case number 1. Because it's not as hard as it seems like it might be.
I'll give it a shot.
All right. You want me to be the resident? Is that good?
Yeah, that's fine. Sorry, is this is the first case or
So,
just?
Yep. So case 1, you will be the instructor / standardized patient one. So you'll be the faculty member.
So you can look at, I think it's page 3. It's faculty standardized patient instructions for case number 1.
Okay.
And then go ahead. Well, here, I'm going to stop the share so that you don't have to look at my screen, because my screen is going to look at the resident case prompt. And then you have that Google Docs available to you, I think. So I'm going to do my best resident impression, and I'm probably going to make a couple of mistakes, so bear with me. Whenever you feel ready, I am ready to be a resident.
Sounds good. So I'm just going to clarify with you. So I'm just looking at page 3 of this Google Doc, and you're going to be the resident presenting to me and faculty?
No, we're doing the one where you are the, you're going to be the patient and Sarah's going to be the resident. So Sarah's going to be asking the history. So we're doing the history taking one.
Got it. Okay.
I just want to make sure you're on the right page though, where it says as the patient and stuff.
Your diagnosis. Oh yeah, where it says my diagnosis is PID. Okay. Yep.
Yeah. And then I'll start asking you questions whenever you're feeling ready.
Okay. Oh yeah, go ahead.
All right. Hi, are you the patient Sonoran? Last name Sonoran?
Yep, that's me.
All right. Hi, I'm Dr. Hawk. I'm going to be your resident doctor today. I wanted to start out and make sure I'm addressing you correctly. What name do you prefer to go by?
Call me Xavier.
Okay, no problem. And I noticed in the chart that you prefer the pronouns they, them, and theirs. Is that right?
Correct.
All right. So the triage nurse mentioned that you've been having some lower abdominal pain, and I wanted to ask you a little bit more about what's been going on.
Yeah, I've been having some pain for about 3 days now. It's, lower in my belly. No, that's pretty much what's been going on now.
Okay. It looks like you had a fever when you came in as well. Is today the first day you've noticed that?
Yeah, I guess so.
Okay. Any other symptoms that have been bothering you?
I sometimes feel like I have to pee all the time, and I think I've been having some discharge as well.
Okay. Yeah, certainly some concerning symptoms. So I'm glad you came in to get checked out today. Have you ever had anything like this before?
I don't think so.
Okay. And when you mention discharge, you're speaking about vaginal discharge, is that correct?
Yeah, vaginal discharge.
And relative to your care today, it's important that we complete an organ inventory. So do you currently have your uterus, ovaries, and tubes?
Yep, I got all those.
Okay. And are you currently sexually active?
Yes.
Okay. With men, women, or both?
A man.
Okay. And is this a possibility that you may be pregnant?
I don't know.
Okay. Are you doing anything currently to prevent pregnancy?
Yes. I mean, I have an IUD.
Okay. That's a really effective way to prevent pregnancy. Absolutely. So, all right. So I certainly, I do have a little bit of concern that you may have either a sexually transmitted infection or potentially pelvic inflammatory disease, which can come from a non-sexually transmitted infection like bacterial vaginosis. So we should probably do a pelvic exam if that's okay with you as part of your physical exam. I would bring in a nurse to stand with me and we would help you through that exam if that's okay with you.
Sure, that's okay.
Okay. So we'll move on to that part of the exam next. And then that's the end of the case. And you, as the faculty member, once they reach that objective, you can say, and that's the end of your case. So now let's talk about it. So how was it being the faculty member / patient?
Oh, you asked me. As playing the patient, as sort of, it's a little uncomfortable to talking about vaginal discharge alone can be uncomfortable, and then putting myself in this patient's position where you're probably, this patient probably is, I mean, I know for a fact that our transgender population is one of the more alienated populations in the ER and has more dissatisfaction with the ER. But that being said, I did feel like you had like a really good cadence when you're asking the questions, and I didn't ever feel like anything seemed inappropriate, or I never felt judged with the way you asked the questions. I was also really focused on reading while we were going, but overall, I felt like you made me comfortable with answering the questions. I like that you added in that you're going to have someone in the room for the pelvic exam. It's just a nice touch.
Yeah. And the specific feedback that you're able to give to the resident that about the way that the speaking cadence that they had made you as the patient, like portraying the patient feel, can be really valuable feedback. So medical students get this all the time from standardized patients in written feedback. When you said this, I felt heard. When you said this, I felt ignored. And that type of standardized patient feedback just doesn't come to residents as readily, because we can't necessarily always afford standardized patients to help give valuable feedback like that. But assuming that persona and perspective of the patient can be so helpful for the resident to learn, because the feedback you give about the way that their speech made you feel can really impact the way that they carry themselves with their actual patients. So thank you for providing that example of debriefing as well, because that's like the next step here is getting your resident debriefed in a way that helps them transform their initial attempt into hopefully an even better attempt the next time. Because there are things looking at that attempt that I'm like, I could have made that better. And that's what comes out in the discussion. If you kind of give that resident a chance to say, oh man, I really messed up on asking about sexual activity or asking about pregnancy, like something was wrong with that. How could I say that better? And there are different ways to say it. And so those are the types of things that you can talk about in the debrief session that you have following the case. Also, thank you so much for being on the spot, Sonia. Yeah.
I thought that Jerome did a really good job asking about sexual activity. And gave examples, because it's such an uncomfortable question to ask. But he physically said, "What kind of sexual activity are you partaking in? Is it penis inside the vagina?" And gave a couple of examples. And as awkward as that feels to say, I think if we say it first, then the patient is probably much more likely to feel comfortable. Maybe is more likely to feel comfortable offering up that information.
Yep, very true.
And Sarah, I'm sorry, I looked away for a second, but I missed the very beginning. How did you introduce yourself and find out what Sonia's preferred pronouns were?
I assumed a convention, which might or might not be correct, of asking in this type of a situation to confirm I'm in the right room. Is this the last name Sonoran, which is the documented last name? And then she said yes. They said yes. And then I asked, how do you prefer to be addressed?
Okay.
And the patient said Xavier.
It's like a very universal approach to it.
It's not as universal as, like in my personal practice, it's not as universal as it could be. If there's a patient that's documented as using the pronouns she and hers, I'm more likely to say, are you Miss Sonoran?
Yeah, yeah.
So it's more of an adaptable thing, which I understand it could be better, in my practice.
Or at least a universally applicable
Yes.
strategy.
And it's interesting, right? Because you brought up an interesting point there, in that we have the benefit of our current new version of Epic will do that for us. So we kind of put that earnest on the triage team to essentially get that information for us.
True,
but you're right, the university of this all, we should also make sure when we walk into the room, because you never know, they might have missed it outside.
Yeah.
And it reminds me that we should really be working through this type of a case with our interprofessional teams, not necessarily just our residents, because the residents aren't the ones doing the triage. So.
And on this particular day when we did this, we actually had nurses with us actually in the case. So it was one of the nurses actually sent us a really nice email afterwards saying that he loved what we were talking about in the room, and he felt like he wanted all of the staff to start showing up at our in situ simulations, because he felt it was just an amazing thing for us to actually do, because he felt like a lot of times those things are missed, and he was happy to see that the physicians were also having these discussions about the patients and how to care for them better. So
I have a question for you both. You said you've carried this simulation out with your residents, correct?
Mm-hmm.
Have you practiced the specific scenario of the attending not getting the pronouns right? With your
With the resident, yeah. So the same way that we did in the video is the exact same way it was. So it's actually written in case 2 for the attending to say the wrong pronoun, to see if the resident will correct it. And in our situation, the residents, I guess, every time corrected the attending. Apparently they didn't feel very shy about it, which was actually fantastic feedback, because it was their program director that was acting as the attending in that case. So yeah.
that's really nice. That's great that
Yeah.
I would just, my question was going to be how did your residents do with that? Because I imagine that may not be like a universal response, because I imagine like a barrier to that is feeling like you can't correct things on certain things, or maybe you don't want to make a big deal out of it. So I was just wondering how you would debrief that if that was the case.
I feel like our residents probably saw it as a setup, as an opportunity in a safe way to challenge their attending, who happened to also be their program director that day. Because our residents are so used to doing cases like this, and having a small challenge like that, where the goal is to try and say the thing that's hard. Like, oh, I'll come down and see the patient in like 3 hours. And you're like, no, it's neck fash. Like, you have to get down here now. In that same way, with this challenge, I think our residents are predisposed to say, no, I want you to really try. They use the pronouns they and them. And I think, I don't know how you feel about it, Jerome, but I suspect that's why we saw that effect in our residents. And I would be curious to see what happens in a different group of residents.
And you're right, actually. And like you're talking about, Sonia, it's a very important thing to debrief well, because, the expectation is our residents might have done that because they're used to doing communication cases and know we might do something like that. But for people who aren't used to it, it's very important to debrief and say, when there are these situations that come up in real life, these are perhaps some ways that you can kind of talk to a superior about, maybe these difficult topics. And we've actually done cases before with the residents about how to have these conversations with their attendings and things like that. And so I think it actually almost shows that the conversations and the briefings previously has worked, and that the residents feel comfortable in saying that, no, this is something that's actually important. And I don't know if you noticed, the way I said it in the case was actually that, I had actually read that this is important for patient care because of X, Y, and Z, and having the residents practice things like that in terms of when they're correcting and attending, right? So it's not like, no, you're wrong. It's, hey, this is something that I've kind of noticed. I don't know if you've seen this before, is sometimes maybe a better way to kind of approach some of those things. And that's something you could talk about during your briefs.
Yeah, it's a very non-threatening way to challenge your attendings.
Absolutely. All right. I think we are needing to wrap up, though. Thank you so much for a great conversation. And I think we need to head back to the main room, right?
This was great. Thank you so much, both of you.
Thank you, guys.
And now you have access to the case. So if you feel like using it, let us know and let us know how it goes.
Awesome. Thank you.
Okay, so we'll regroup at the 30 for final comments and stuff. So we can talk at leisure or admire our various gardens in the background.
Yeah, I'm actually, I'm going to switch over to my phone because I'm going to head over to the hospital to see my mom now with her new bionic hip. I'll still be listening in now. You just won't see me.
Nice.
Welcome back, everyone.
Do we have a little break or do we?
Well, I was gonna, Monica and I were texting. I leave it open, depending, because it's that depending on which part of the country you're in. It's 6:30 my time, and I don't know where everyone else is at. But if you're feeling tired and you want a break, or if you're feeling tired, we can try to do the wrap up now and hopefully get everybody out a little early. It really depends. What does the group feel like doing?
There's only 16. I figure people need at least a bathroom break for 5.
All right. Potty break all around.
I'm just going to put everyone's email addresses up. So if any of the participants wanted to reach out to us, you can do so. Oops. All right.
Oh. So.
Also for any of the participants who are still on right now, if you want to shoot me an email, if you want just the slides, I'll put them into a PDF format. I don't really have any way to get individual emails otherwise, so go ahead and shoot me an email. I'm happy to put the slides that we used, put them together and send them to you so you can review them. Although again, one of the small sessions groups was taped and all of the intro was taped and will be available.
So how did everyone feel that went? Thank you so much for attending, by the way. I know it's a long day, and it certainly it feels like Zoom makes these things a little longer. Maybe that's just me.
I actually think the small group stuff made the Zoom go by a lot faster because we were at least not actually moving, but like the groups were changing a little bit, or the topic changed if you weren't the one moving. And so I think that actually helped make the time go by faster, because I think 4 hours of just sitting there listening to a PowerPoint is hard on Zoom. That's the nicest way I can put that.
Anyone have any big thoughts? Any of our participants have any insights, thoughts, comments, feedbacks they want to give us at this point in time? Anything we can clarify?
Well, I'll just start by saying I really appreciate the feedback that we got from all of you about the cases that we were presenting. It's certainly great to hear additional perspectives. So thank you.
I think it was really valuable to go through like some of the cases that you guys had developed or were presenting, and sort of your thought process behind why you chose the things you did, and sort of how you did the like pre-brief and particular objectives. I think in terms of sort of developing further cases and sort of learning modules, having that insight I thought was valuable.
It did occur to me that I should have probably introduced the concept of advocacy inquiry a little more in my introduction. I apologize for that. For folks who don't do SIM, it's a method of exploring someone's framework, what they're thinking about when they do something within simulation, and the idea being that historically, you get what's lovingly referred to as the fecal matter sandwich, right? Compliment, fecal matter, compliment afterwards. Or someone just lays it right out there and says, you screwed up, you did something wrong. The idea behind advocacy inquiry is that if you're going to ask somebody who did something wrong, they did something wrong, they know they did something wrong, and you may as well just admit it and say it like right up front. So I noticed you did this when, I noticed you wanted to give epinephrine when the ACLS protocols demand that you give amiodarone at this point in time. I'm just curious, why did you choose that? Right. So the idea is to try to take you're judging somebody. Everybody knows you're judging somebody, even if you give them the compliment sandwich, but to admit you're judging them and actually ask them in a curious fashion why they did it, if that makes any sense. The SIM people are nodding. Other people are just looking at me. It's okay.
This works well with husbands who don't take out the trash too. I noticed that there's a smell in our kitchen.
Or I'm interpreted as passive aggressive.
Yeah, no, it actually doesn't work well because they get really mad when they realize what you're doing.
As a Canadian, passive aggressive is the norm in Canada. So I just know used to this.
Stereotyping, Mike Falk.
It's my own country. So yeah, I mean, so if you want, we can probably put in some references on debriefing styles. There's a really good one by Walter Epic and Mark Auerbach on debriefing. So we can happily include that in the list of references if people think that'll be helpful. Anything else, folks? Otherwise, I don't want to keep people from living their lives. No. Well, I mean, thank you so much for coming. I really appreciate that everyone showed up. It's death by Zoom is what I describe my new life these days. But I'm really happy that you guys came to join us for 4 hours of Zoom. So I appreciate the commitment.
And I'll just tell everybody, whatever you end up doing in your own spaces as you move forward, you should publish it, because there's not enough out there, and it will get published, because as we were putting things together, we were like, there is nothing written about this. And so the time is now, you guys.
Oh, there's my dog again. And I agree with that. I mean, I'd say this to everybody, there's really not a lot of publish. You know, if you're doing anything new, you should look to an eye to publish it. But especially it's something like this where there's no rules really about what's going on, right? And historically, what people have done to teach this is pretty crappy. We've all sat through a lot of those 1 hour long lectures, and I'm not really sure what you get out of it. So thinking outside the box and taking novel approaches to doing things, go for it.
Especially like for DEI training, it's, we keep trying to find ways to validate it. And most of the time it shows that we're not doing the best job of training it. Like even just teaching, like using the IAT, most of the time when they look at that, it's not terribly successful in changing. So, I mean, certainly there's a lot from a research perspective in that, right? It's, whatever. Anyway, that's a whole nother topic. But the point is there's plenty of room, and, simulation, as we're sort of hopeful, could be one of the great tools, and it's got enough of a history that there's good ways to validate and look for how effective it is in teaching things. So, you can come up with your own sim and look to validate it for teaching different topics. And there's so many topics on diversity, equity, and inclusion to teach, so many. So the world is your oyster here. Exactly.
Exactly. Yes. If you guys don't have any more questions, if there's nothing more we can say, the other thing to always remember is SAM, both the Diversity Academy and the Simulation Academy, we are resources. We are here to help you guys. This is my plug as the president who's leaving. But we are here to help you guys. So there are the Simulation Academy has research consultations that we will offer you. So if you have an idea and you want to get some feedback on it, call us. We're happy to give it to you. We do the same thing for educational consults for people who want to develop curriculum and courses to try to teach novel ideas. I know CORD does similar things too, because we work with CORD on this stuff. So there are resources out there, and we're more than happy to help you. Cool. Well then, on that note, I got a bowl of ramen waiting for me somewhere.
Alrighty, everyone. Thank you so much. Have a great rest of your afternoons, evenings. Follow us on Twitter and Instagram.
Yeah. Thanks, everyone. Does the faculty want to hang out for a few minutes?
Sure.
Sure. Oh. Hey,
shout out to Evan from SAM.
Yes, thanks, Evan.
Breakout rooms and make it happen.
You're very welcome.
Great success.
Yes, thank you for taking that off of our hands very much.
I have to massage my Zoom face.
I know. Well, if you want to see I did. They had me do a Zoom telemedicine thing, so for the telemedicine workshop tomorrow. So if you want to see me breaking all the rules and doing silly things, you can watch that. But yeah, I wanted to rub my face for a lot of that meeting at some point in time.
You're talking about telemedicine, or you're serving as like a person in the SNP?
I'm the telemedicine provider.
Your acting debut.
Not my first time. How you got? So how'd that go for everyone?
I'm glad that it was actually as small as it was, because I think that fostered real conversation. I think if we had like the original sort of vision that we would all end up with groups of like 10, 12 people, that I don't know that there would have been as much conversation. Sort of interesting to figure out what that sweet spot number is.
And it was definitely like, just however many people were like, I'll hang out for 4 hours on Zoom. But I think, the folks that were here were really engaged and willing to participate, which was awesome. We had volunteers for our cases, all 3 sessions, which I was like, I don't know if they're going to volunteer, but we're going to try. So.
I thought it was cool. We had medical students that were here too, that weren't necessarily like just the participants from the ambassadors group. And so I think that was cool. I know that the med students are being tapped for input onto a lot of these type things, which we can all go to town on whether or not that's appropriate. But I do think that was probably helpful to them, and they seem to get a lot out of it from their comments.
How do we get the feedback on the session? Do you guys get it and then you'll disseminate it, or does it not happen?
No idea.
I don't know how to do this.
It's a mystery.
I don't dare ask. Yeah, I don't dare ask at this point in time.
I think they collate the feedback and then they provide it to us afterwards. So, which is great, because we want to do this again next year. And that would be, as a plug, it's in New Orleans. So,
well, it'll be interesting, because technically the recording is open through October, I want to say. So I don't know if I guess technically that means there's rolling feedback through that time, because they have to give feedback for CME.
Yeah, but I doubt they're going to offer CME all the way through. I think Cord cut off getting CME for watching the videos like 1 week after.
No, I think they said July for CME.
Wow.
I don't know. I got some email that said like CME ends on some date that has already passed.
Oh, that sucks. Yeah, I think they I was surprised. I remember looking at it thinking and being surprised at how long the CME was going to be offered for. I think that's part of the thinking as to why the conference is kind of expensive, because they're offering you a prolonged period for which to get CME for it, maybe.
Wrong with that. I don't know.
Benefit of the doubt.
Yeah. So hopefully we'll get feedback from them, and maybe we can use it if we do it again, to inform like what we do next year. I think the Zoom was problematic, because I do think I think you can make it more hands-on in person, and I actually feel that there's more of an onus for people to take ownership and be hands-on when they're in person. I'm curious. I didn't take part in the procedural training workshop we did this morning, but I was wondering. I'm curious to see how that worked out in the real and on Zoom. But yeah, so I do think there's a space for this next year if folks are still interested, and if we want to continue it. So we should keep that in mind.
Well, I think this year is also kind of hard, because they put there were so many workshops, and a bunch of them are conflicting, right? Like 2 DEIs running at the same time, 2 SIMs running at the same time. So people who are interested in both still have to pick one or the other, which is kind of not cool, but whatever.
Yeah, they're usually better about it. That's usually the Society for Simulation in Healthcare is the one that tends to overbook and then cancel. Having been a victim to that. Any other thoughts, guys? Feedback? Everyone okay? Everyone happy? All right. Cool. well then I got a date with a bowl of ramen. And I will, for those, I mean, if anybody wants to, please feel free to come to the Sim Academy meeting on Tuesday. You're always welcome. I know.
Thursday?
What's that?
Thursday.
Thank you. Thursday. Sorry, 4 hours. Yeah, enjoy the rest of the conference. Thanks, everyone. This is good.
Yep, thanks.
Thanks, you guys.
See ya.
Have a
Thanks
good
for all
one.
your help.
Great.